Ravi?
Kiran, are we live?
No, not yet. Seconds more.
Please confirm, Kiran, then Dr. Kasturi sir will start.
Then we'll start. Already both operators are ready.
1 second, sir. We are just connecting live, sir, to the website. We are connecting and we'll confirm it to you.
Ravi?
Yeah, Kiran, are we live?
No, not yet.
Not yet. Seconds more. Please confirm, Kiran, then Dr. Kasturi sir will start.
Then we'll
call.
We are live, Ravi.
We are live? Sir, Kasturi sir, we are live.
Shall I start? Good evening to all of you. Warm welcome to IPS Summit. Today we have two live case transmissions, one from Max Hospital by a very senior and eminent cardiologist, Dr. Balbir Singh. Another one who is equally well known and very senior faculty member, Dr. Gopal Krishna from Ayush Hospital, Vijayawada, the Max Hospital from New Delhi. Everybody is very familiar with these centers. And today we have sessions on functional PCI, mainly usefulness of physiological assessment, followed by image-guided PCI and case-based approaches and keynote lectures. So already we are running short of time. Without further ado, today I'll request some of the expert members to join on. Mainly today we are going to have Dr. Neil Johnson from USA and Dr. PC Rath, and both are going to join very soon. And meanwhile, I request Dr. VT Shah and myself will be moderating this session, and VT Shah will be the expert panel member. Sir, are you able to hear Dr. Balbir Singh?
Yes, I can hear you.
Sir, over to you, sir. You can proceed with your case.
Yeah, Dr. Kasturi, Dr. VT Shah, it's a pleasure to be here. We are going to present this Mr. 65-year-old gentleman, and I have Dr. Brijesh and Dr. Pratik with me. So Pratik is going to present to you the case, and then we'll show you the images. It's quite a tough case, so we'll need your inputs. Hello, Cole. ये present कर दो ना. Mic नहीं. मुझे दिखा दो slides. Are you able to see our slides?
No, slides, not yet, sir.
Balbir, we can see your cath lab and you, but not your slide still.
Okay, so I will just briefly tell you this is...
Yeah, you can briefly go through because that is sufficient for us.
So he's 65 years old, ex-smoker. He left smoking about few years back. But
that CM is covering your face. Can you just remove that CM? I think totally covering the operator.
Yeah, so he has a history of CA lung. And he received the first cycle only a couple of weeks back. And he's a non-diabetic, non-hypertensive. He presented with 1 hour chest pain on 4th January at morning 6:30 a.m. At that time, he had an inferior wall MI with the RCA, which had 95% stenosis with ST elevation in the inferior leads. Can we show the angiogram? So we'll show you the angio now, which had been taken on 4th of January. नहीं ये नहीं है नहीं उसके पास है ना यार So we had stented the RCA. The ST settled down immediately thereafter, and this was on the 4th of this month, only 4 days back. So you will see the images now. Are you seeing the
slightly
images?
Louder, Balbir, slightly louder. We can't hear you intermittently. Your voice is getting lost.
Okay, can you hear me now?
Yeah, this
we
is
are able
better.
to. Yeah.
And can you see the images?
Yeah,
of,
we
even,
can see
we
the
are
images, right?
So this is the right coronary injection. So you see the RCA running. So there's a ugly dissected mid RCA lesion. And this RCA is filling the distal part of the circumflex. You can see a big collateral from the PLV branch going all the way into the distal circumflex. Do you see that?
Yeah, okay, we saw that. Yes, distal
Next.
circumflex and a distal OM also possibly.
Yeah, so this is the second picture of that ragged lesion which caused the myocardial infarction. It was clear ST elevation, so he was taken to the lab with immediately, and the ST resolution was perfect. So you see the big circumflex filling from the PLV. Next. Next. Now we come to the left side. So you see a tight lesion on the proximal LAD. You see a lot of calcium there. You see some distal left main lesion. Next. And in the mid LAD, you see a muscle bridge. Right?
Yeah.
Next, please. This is the LA caudal view, which makes the case very horrifying. So you see the circumflex is occluded, and there's a big obtuse marginal right at the first obtuse marginal and then a second obtuse marginal. The lesion in the obtuse marginal is at the ostium, and then it extends to the ostium of the circumflex. And then we have calcium, we have distal left main involvement clearly seen. So this is what we have on the angiogram. Today's pictures will show you now.
So we could not see that caudal view.
We'll show you again. Aaj ke dikha do.
Yeah.
So this is today's views. So this is AP cranial. You see the LAD mid and a muscle bridge in the mid part. Calcium you see. Do you see the image of today? The guiding catheter?
Yeah, we are able to see
Okay,
the proximal and distal LAD.
Right. So this is cranial view, clearly showing distal left main involvement. Next. And this is the caudal view. See the OM branch, the first OM.
Yeah.
So this is clearly looks significant to me. It is reasonably big to be protected and taken care of. So we have a tough strategy because you have two right angles to take care of, one through the left main, and then you go to the OM1. OM2 is the smaller of the two, and then after that the circumflex is occluded, and you saw that what was filling from the right system. So this is what the strategy, what the situation is like. Now we would like to know from you, what are your inputs on this? Eleocol.
So Balbir, you have gone radial, and is this 6 or 7?
This is a 7 French transradial.
Yes. Very good.
And the MI was also treated by a radial approach. So we same using the same.
And most important thing is, I heard you say some cycle was given. Was it a chemo cycle?
One chemo cycle, yeah.
For which malignancy?
CA lung.
CA lung. Okay.
So ideally, so he's not a surgical candidate at all.
Right. And the other thing is that when he suffered this MI, was the platelet count and the total count very low because of the chemo?
It was normal. So the leukocytosis was there. The first count that we got was 36,000. We gave him some antibiotics. The counts are normal. There was no source of infection that was seen. So I have gone to the OM now.
Worry is there any chance that this chemo which they give is going to decrease the platelet count on the 21st day or something at its peak action?
So I have discussed with the oncologist today, and he said it will be safe to give antiplatelets.
So giving dual antiplatelet is not a problem for them.
Not a problem.
Very good.
So I have now just crossed the OM, and what would you think would be the right approach to this patient?
So now going to the technical part of it, the angio part of it, obviously we see that you have crossed the LAD also.
Yeah, LAD and OM are now wired, both of them.
Yeah.
So there are two things in my mind. First, we know this history, we just tackle the LAD and this and do a provisional stenting and forget of the OM because it's too complicated. The second strategy is if we go for 2 stents, we think that decay crush would be the best strategy in this situation, because, or a mini crush, one of the crush techniques, because of the angles that they are involved. Cool out is out of question. The tap may be useful, but we are going to evaluate by OCT the LAD and the OM both, and then we get some idea as to what we are going to do. Are you called?
Right. So for the time being, I think then we are leaving the circ lesion because it has a good collateral.
Yeah, so distal circ I'm not going to touch.
Correct. So I think that's a fair strategy because with this comorbid condition, trying to do something would be more complex. So most important is to get the LED first sorted out and see how it looks like, and
is busy, sir.
then of course the OM DK crush looks okay for this angle and the vessel sizes which you have. So let's go through the OCT and see how much calcium is there and whether it would require any pre-treatment or whether it is deep inside.
I think for this patient, provisional stenting is also the very right strategy because the right corner is dominant, LED is very big, and the L6 is looking like a non-dominant secluded vessel, and considering the background of the morbidity and everything. So I think the first strategy, if at all we are going for a two-stent technique, DK, as sir said, DK crush is the preferred strategy. But my opinion, better to go with the OCT assessment, even side you can see.
Yeah, so that's what I'm planning to do.
Yeah. Welcome, Dr. Kirti.
Hello. Hi.
Hi, Kirti.
You can moderate the session and.
That's here.
So can you focus on the OCT now alone?
Yeah, we'll show you that. Hi, Kirti.
Hi, Balbir.
So we have a case which will be of a lot of interest to you. This gentleman had an MI about on 3 days back, inferior wall MI. Yeah. We treated his RCA, and now we are in a distal left main proximal LED and an OM which is significant stenosis and a significantly large vessel. Can you show the LAO caudal to Kirti before we show the OCT? Next.
I'm sorry I ran a little late, but...
Okay, this is the LAO caudal. Do you see that?
No, wait 1 minute. Yeah.
So this is the LAO caudal projection. So you see a OM1, OM2, then the circumflex is occluded, which is filling very well from the RCA collateral. So I'm not too worried about that. The patient has a background of a C lung on chemotherapy. So we have OM1, which is reasonably big, I would say moderate sized OM, but it has a lesion at the mouth, and then there is an ostial circ stenosis. So one thing was clear, that I can't afford to lose this branch by all means. So that was one. Second was, we were debating a provisional versus a two-stent strategy in this patient. So we thought, let's do an OCT and see how bad is the calcium in both of these OM and the side branch and the LED. So we have the OCT on the LED now. Can you show?
How much more is the circumflex in another caudal view? I mean, is there a lot of circ area? Or?
So the circ area, if we show you the RCA fills up the entire distal circ area through a very big collateral. So this is the only OM which is of some significance, but it is a moderate size. I can't say it's a small sized OM1. So you see this eleocranial view, this OM is taking off and going back.
Yeah, right. Yeah. It's a large one.
Yeah. So this is what the situation is. So we can't afford to lose it by any means. We know the background of a CA lung also. So we have to be a little gentle in doing all these strategies. We'll show you the lesion. I did not pre-dilate the LED, so the OCT images are not that great. Can you go back? ये measure करेंगे diameter? हाँ, यहाँ measure करो. Okay, so it's about नहीं इतनी जल्दी नहीं, it's धीरे. So about 3 millimeter EL diameter. So now we'll show you the lesion and the calcium within it. So the calcium is there, but it's not an arc all around. And as we approach the lesion, we see the calcium on 3 to 6 o'clock, but it is thick, but not an arc. This is the lesion, which is more of fibrosis than a lot of calcium. So the strategy is going to be a non-compliant balloon for sure for LED. That's what I feel. And we extend to the distal left main. We coming close to the distal left main. There is the distal left main. This is the circumflex coming off, and this is the distal left main, which clearly is smaller than what you see the proximal part. You see the round proximal part, and the area is 11.7 in the proximal part, and in the distal, can we show the distal left main again? Just before the bifurcation. Go down, go further down. So it's about 5.4. So clearly distal left main is involved. There's no doubt about that. So we have proximally, distally the diameter is 3, and proximally in the left main, I guess it's 5. Can you check again? So we don't see the EL. Can you measure the lumen diameter? So it's about 5. So 4.5 balloon would be what would be my choice here. Now I'm going to view
what is the second diameter over there?
The second diameter transfers दूसरा देखना, right angle. 4.
4. Okay. Because in the left main, the catheter is never, completely in the center. So there's going to be some beveling of that lumen. Yeah. So
and with a left main of a 5 size, I think OCT tends to get an image which is not circular, like you are seeing here. You don't, in such big vessel, you won't get a circular.
Right? So it's like an oval image because it's not a transection completely. Yeah. So my question to you, Balbir, is this OCT image good enough for you to determine?
No, it is not. I am going to dilate
with a proximal landing zone.
Yeah, so I'm going to dilate with a 2.5 balloon, high pressure, and repeat an OCT in the LED. But I'm doing
the first question I have is the landing zones. Have you been able to determine your landing zone?
So there was a
both ends.
So I am going to repeat the OCT because I have to dilate and get a very good image. So I'm doing an OCT of the OM now, trying to look at the ostium, 2 ostia, one at the OM ostia and the one at the left main ostia, because this is going to be very crucial.
The OCT, sir, the OCT showing the bifurcation angle is unfavorable. Acute carina angle is
that is true.
50 degrees.
Yes. And Can you show the angle again? The last few, this is a very important point.
That bifurcation point to carina tip length is
we'll
shorter.
Show you that. Circumflex ka ostium dikhana.
I feel the side branch closure is very high based upon
OCT so image. This, can you show this angle? So this angle doesn't look that bad, Dr. Kasturi.
Yeah.
Just look at the transfer. Carina is not that bad. Yeah. The carina is there.
But the length is shorter, bifurcation point to carina tip, definitely less than 1.15. To me, it's appearing like that. And once you compress with provisional strategy, most likely that may...
See this angle? And carina tip to the angle is not so bad.
See the length, BPCT length?
It should be less than
length measure.
1.7.
1.7?
No.
Yeah, 1.7 is the cutoff.
Yeah, let's measure.
But I think it's less.
ये नहीं, वो जो tip दिख रहा है ना कराइना में, हाँ यहाँ से ऊपर तक.
वहाँ से वहाँ तक.
It is looking less than 1.
Branching point से लेकर CT. हाँ, कितना है?
1.6.
1.6.
Okay.
It's okay.
Yeah.
So it's not so bad.
1.6.
So
okay.
New recording.
Achha, let us see the ostium.
So we'll show you the ostium of OM.
The plaque and the area. And
we'll show you that.
Vessel size.
Once let me handle
with a tight lesion in that OM, you're going to get a great image. Yeah.
No, I think we are getting good images. That's why I started.
Okay.
Start. So we got a good image. So वो ठीक नहीं है, छोड़ दो इसको. ठीक नहीं आया, छोड़ दो. एंजियो कोड ठीक नहीं आया. Okay, just run it. No, go back. Just run it. We'll take a measurement. Now take a measurement. EL is very nicely seen, so we'll take one measurement. It's 2, but I have not opened this vessel. It will become definitely bigger, but I would go with the idea of 2.25 stent. Next, keep running. So it's not as long as I had actually thought.
Very short segment.
Yeah.
I think less than 5 mm.
Yeah, so this is the ostium of the left mid, or ostium of the circumflex. L6. So it's not bad. Keep going. So we go to the left main again. So this is the distal left main, which we already saw is diseased. Yeah. Go further down. And we see a huge left main here. Yeah. It's clearly around 5. Yeah.
So that is a great landing zone actually, because you can see the EL at least in a little bit of that.
Yeah, right. So now this is what we are at. So I'm going to open the LED first and probably look at the distal landing zone clearly, which I'm not happy so far. 2.5 balloon. Maybe 3 balloon also. 3 level. So what would you think? We should go for a decay crush or?
As per the criteria, what I feel is that the diameter is less than 2.25 mm and the length is less than 5 mm. Right. As per the bifurcation EBC guidelines, provisional is the preferred strategy for this one.
Good.
And keep the jailed wire. If needed, we can cross and put the T-tap. That's my
not bad idea.
Oh, and you can still do a kiss and come out.
Yeah.
Yeah, I will. And we'll leave an option for tap if it starts closing.
Yeah.
I think the distribution of that OM is fairly large.
Yeah, that is true. It's a long branch.
And I think that we should not discount that.
Can you come to the ostium and find out how much is the plaque area of the
it's very significant.
Lumen area was quite low. It was less than 2.
Yeah, so the plaque area is
less
also
than 1.92 actually. So
it'll go up 12 down. So the balloon is opening quite well, which was what was predicted by the OCT of the calcium being not too much, even though fluoroscopically it looked like huge calcium.
Dr. Balbir Singh.
Yeah.
Meanwhile, we'll go to Dr. Gopal Krishna's lab and we'll come back to you. Meanwhile, you can. Yeah, Ravi.
Kiran, can you switch the labs, please?
12, 14, down.
Are they ready, Ravi?
We are getting them, sir.
1 second, sir.
Meanwhile, what do you say, Dr. Kirti Punamia, regarding this case? Because it's a short segment lesion and 2.25 diameter. Though length is more, the area of territory is more as per the guidelines. My opinion, what I feel, do the provisional if needed, kissing balloon.
I think guidelines are not rules. Here,
otherwise, go straight away with the 2 stent technique.
This is what I would do with this patient. I mean, you do not want to compromise that branch, lose it at any point, and then try to chase it because it's a large branch. It has a very large territory.
Sir, we are with Ayush Cath Lab.
Yeah. Welcome, Dr. Gopal Krishna.
Hello.
Very nice to see you.
Nice to see you.
Yeah,
this is Ayush Hospital.
2 expert panel members. Dr. VT Shah is with us. Dr. Kirti Punamia.
Hello, Dr. Shah.
Hello, good evening.
Hello. Good evening. Good evening, everyone out there. Dr. Shah, Dr. Sridhar Kasturi. Thank you, Dr. Sridhar Kasturi and Imaging and Physiology Summit for giving the Ayush Hospital the chance to.
Thank you very much. Pleasure is mine for having you.
To transmit a live case, and we have the patient. I'd like to introduce patient. He will say hi to you. Dr. Prasad Garu, he is a physician. He is graduated long back from Mysore. He's now practiced around Tenali for some time. He's a very cheerful gentleman who's very cooperative, and he's 86-year-old. And now I introduce my colleagues, Dr. Sudarshan. Sudarshan, can you come on to say this and hi? And Dr. Raghu. This is Dr. Raghu, my colleague, and Lakshmi, and Dr. Dashrad, and my chief technician, Dr. Prasad. And let me introduce the case first. We have this patient. Can we go on to our presentation, please? Rohini? Can you see our presentation? Presentation mode, please.
Yeah. Go to the next.
Presentation, please. Presentation mode. This is the previous meetings we have done during the COVID webinar, and just we go through this for a half a minute. And Dr. P. Siraj, Dr. Shah, and Dr. The panel, and Dr. Sridhar Kasturi were there during these meetings, and these are our team working in the cath lab eagerly, and this is my team in the cath lab, and this is the cardiologist we are working with, and we are live from Ayush Hospital. Live case. Next, please. So we have an 85-year-old physician. He presented to a hospital in Hyderabad in May 2020 with anterior MI. He never had any history of MI or CVI in the past. Presently, he has come to us with exertional angina. At that time, there was a PCI was planned. Because of the COVID situation, it has been postponed. He's a long-standing hypertension and COPD. He had a history of blunt chest trauma with left pleural effusion. Actually, he has come to us with episodes of giddiness, and he has been on beta blockers for his coronary artery disease, and our electrophysiologist did a Holter, and it has shown 2.5-second pauses, and because the drugs are a must for him to continue, a class 2B indication for permanent pacemaker, so he underwent a VVIR pacemaker in October 2020. He has been mostly on sinus rhythm at a 60 heart rate, and his echo has presented with ejection fraction of 55. Because of the COPD, he has a moderate PAH with RV systolic pressure of 42 plus pulmonary artery pressure. His ECG is mostly in sinus rhythm, as I was telling you, 61. The frontal QRS axis is minus 45, PR is 0.20, and he has a poor R wave in V1 to V3. He has a CT chest done before the permanent pacemaker deployment in October, which has shown significant disease in the left upper lobe bronchiectasis, fibrosis, pleural thickening, and bilateral ground glass opacities, and our radiologist felt it is Corad's 3. His labs are, his blood picture is normal, serum creatinine is 1.12 with a GFR of 55 ml per minute. Next slide, please. So we calculated the surgical score. He is a candidate for, I will show you the angiogram surgical score. With this thing, if he goes for surgery, these are the STS new data with the data version of 4.2 score. So next slide, please. This is the picture. You can see a small circumflex artery in the OM, and there is a tight lesion at the ostium of the LAD, and a lesion in the mid segment of the LAD with calcification at the distal disease in the LAD. Even despite the anatomy is not very attractive for surgery or PCI. Next slide, please. And that is the disease. He has an osteal disease followed by sort of an aneurysm, then a long disease extending into the mid LAD, and there is a large diagonal, and after the diagonal there is a focal lesion and the distal disease. Next slide, please. And you can see in this picture, you can see the osteal lesion in the circumflex, which was not seen in earlier pictures. You can see the osteal lesion in the circumflex. Next. That is the problem. One of the problems with this patient is he has a very, very short left main. Next slide, please. The right is huge with a small lesion, significant lesion in the proximal RC PDA, but it's not a big artery. BLVB is huge. Rest of the disease is not significant. Next slide, please. So he has a history of remote MI, presented with external angina with preserved LVEF, significant lung disease, a CKD stage 3, high STS score. Coronaries are calcified with short LM, critical osteal LAD with sort of aneurysm, borderline mid LAD and significant distal LAD, LCX osteal and critical mid LCX disease and significant proximal PDA disease, but is small. And he underwent PPI in October 2020. So next. So what shall we do? Surgery or PCI? If PCI, are we going to revascularize totally or partial? Is it rota, IVL, rota or IVL both? Or cutting balloon? What are the interaction between the IVL and PPI pacemaker? If you are doing LV, LM, Is it provisional or EDS? If EDS, is it decay crush, decay collate, or collate? Collate is out of question because both arteries are diameters are way different from each other. So that is the scenario here. Can you discuss and tell me what I will show, or you want me to show you how what I have done?
Yeah, you can proceed, sir.
Okay. Next, get back to, just before that, I will show you one thing. Next slide, please. So this disrupt calcium CAD3 inclusion criteria is either by angio and IVS or OCT. That is what the criteria are. Everybody knows it. They are available in the net. Next slide, please. So in pacemakers or CRTP, CRT devices, generally safe to be programmed to VVI mode during IVL. The rate should be more than 65 to avoid VF and shock topics. Rate response mode is to be switched off. The pacemaker is to be tested fully after the procedure and before discharge. There is some damage to the sensor portion has been described with ESWL, but not with shockwave lithotripsy of the coronaries. Next slide, please. Shock ectopic. We have seen the shock topic in this patient. We did IVL this per patient. Induced VTF, VF are rare. Only one case report. This phenomenon was formally studied in the DISRUPT 3 study. It induced a capture was noted in as high as 41.51% of cases. We have noted in this patient. However, there were 0 cases of sustained VTR, VF during immediately after IVL. Last time, one of the operators was telling me in one of the live cases that he had one patient who had a VT. Next slide, please. Thank you. That is the VT, the case report where IVL has produced a VF. Next slide, please. Live. Can you go over to the picture? So yeah, that see that. So what? Because we have I wired both the branches, then did the angiogram. You can see I wired the circumflex and I wired with the balance wire the LAD, and that is the next slide, please. Next slide, please. My plan was to do the circumflex first, dilate it and possible stent it, then look at the LAD. So I wired the circumflex. I took a 2.25 by 12 balloon, tried to get into the LCX, and it's on balloon not uncrossable lesion. So the balloon is no way crossing the lesion. It's very, very tight. So what I did was I took a microcatheter, fine cross, and with a lot of difficulty I could get the fine cross across into the even for the fine cross to get into the distal the circumflex was very difficult. So that's the difficulty I had with fine cross to getting there, to exchange it to a rotafloppy wire. Next slide, please. So I changed it to I got across, I changed it to rotafloppy wire. Next slide, please. Then I took a 1.2 fiber, and this is the difficulty I had in getting. Next slide, please. See. So this is a 1.2 fiber. Next. That is, I can get through it. I did a polishing run. Next slide. Then I exchanged by trapping to a BMW wire and remove the microcatheter by trapping with a balloon. Next slide, please. So then I took a 2.25 balloon and dilated the circumflex lesion in the mid and also at the ostium. So with the same balloon, I went into the the 2.25 balloon. I went into the LAD and dilated the LAD lesion. And then we did an OCT. Can we show the OCT, please? First run. Of the LAD to mid LAD to LM. I want to know, I was debating whether to do IVUS or OCT in this patient because the left main is short. I'm not sure whether I can get the left vein properly or not. Probably I was also thinking of doing IVUS for this patient because I can get the left main. You can see the picture on the screen. There is a lot of calcium distally, a distal reference which was healthy. Will show you right away. And we are into the proximal. You can see the calcium there, severe amount of calcium. And this is the aneurysmal segment which measures around 4. Oh, next slide, please. Around 3.54. Next. So, but the LM, as expected, there is a lot of blood, this thing, artifacts in the short left main. So with this seeing, we that is the distal. Stop there. That is the distal reference point beyond in the middle AD, just above the diagonal. And we found out that if you look at the screen, that from 7 millimeters to around 15 millimeters, there is a lot of calcium there. That's the calcium. Right. Come back. That's the calcium you can see with CVA score of 4. Come back. And this area, in between area, is not bad. Not that 270 degrees of arc, or so it is 90 degrees calcium, deep calcium. And again, proximally when you are going into the ostium, proximally when you are coming into the this sort of aneurysm segment, from here onwards, you can see the calcium again all around. You can see the significant amount of calcium. Now you can see this calcium. See the calcium now? Yeah, that's the calcium. Come back. So those are the areas where the distal, and so we thought by this, let us, because this even 1.75 bar will not do much for this lesion. So we chose IVL for this lesion and used IVL. Then we used a 3 millimeter IVL, took a 3 millimeter IVL. This next slide, please. So initially dilated with a 3 millimeter balloon so that the IVL balloon will expand properly, the whole lesion, 3 by 18, and run, please. Back, go back, previous run. Next slide. You can, that is after pre-dilatation. You can see the pre-dilatation. Next. This is the first IVL where we chose the distal part of it. Next, this is we have given 10 plus 10, 20 pulses here. Come back. Next slide, please. That is 10 and 10. Next slide. Next one. Then we have given another 10 and 10 here in the proximal where the calcium is very much. Then we have given in the ostium also another 20 pulses here. So another 10 pulses, total 30 pulses in the ostium and 30 pulses in the distally and 20 pulses mid. We have 80 pulses in the IVL balloon. That is what we have done so far. Now, that is the last 10 pulses we had. We used it distally. Next, come back. So that is the result. Next slide, please. Then go back. This is the angiogram picture after doing the IVL. I remind you, there is a lesion beyond the diagonal also, and distally also there is a lesion. I don't know how far I'm going to do it. That is what angiographically we have seen, but you also notice that the LCX ostium still, even after 1.25 burr and followed by a 2.25 at 18, still it is stenosed. That is, and it's not a huge artery. It's not dissected distally. It's a small artery, and after this we did the OCT run again. There, the next slide, please. You will see the OCT on the screen, please. OCT on the main screen. OCT central screen, please. Yeah. See, you can see nicely the cracks.
Yeah.
The cracks are seen. You can see the cracks. Produced by the yeah, I think we have achieved what we
Beautiful
wanted.
demonstration of nice cracks in the calcium plate, and this is the importance of showing how the OCT is helpful in really have you done the adequate block modification or not. This is a very nice demonstration, and the circumferential calcium, long lesion, and very thick calcium, more than 0.5 mm. Almost, I think it's a 1 mm, more than 1 mm depth, I think. It's a very severe.
Now that's what I have done so far. Now what you want me to do? I have that length between that the two segments. Can you go back to the angiogram screen and show the last angiogram picture?
Dr. Punamia, you can comment. Dr. VT Shah.
Yeah. No, we are really impressed by all the demonstration which he has actually done. So we were trying to understand ourselves, the planning and everything which has gone in this case, and especially the presentation also. So far so good. But now what I think is, by dilating the circ, you have already committed to two-stent strategy, right?
No,
You have
not.
dilated the ostium also.
Yeah. That's right. That's right.
So
but
you have
not
committed
exactly.
yourself to two-stent strategy. So now you have to decide what two-stent you want to do depending upon the angle, and whether you want to go for DK crush or whether you want to go for T-tap. I think from this angle, it looks as if it is almost 90° one. So we have achieved a good lesion preparation. There is no doubt. And your 3 millimeter balloon worked wonders in this case, because I had some apprehension about the proximal, osteoproximal, where the vessel size looks bigger, but the lumen was small. So the 3 millimeter worked there also. So I think you were lucky that such an expensive equipment was saved.
So the problem now is what you want me to do.
Now the other question important is whether you want to leave that ectatic segment without any stent.
That's an interesting point, Dr. Shah.
Or whether you want to cover it. That's the most important thing which you have to decide. And we can take Kirti's opinion as to what. But honestly speaking, for that short left main and ostium and all that, we would have loved to have some IVUS images. But it's all right. At least if you have this, we know that we can cover that. We'll have to cover up to ostium. There is no question now.
If you want me to do, I will do an IVUS and show it to you. But I think you have to go back to your lectures and come back. It takes a bit of time because I was not prepared for IVUS. I have to set it up, and it's not a co-registration.
So let us first hear Kirti's opinion, how he would like to go ahead with this, and then you can do everything, and we'll go to the lectures.
Yeah.
See, obviously, left main to LAD is not one lesion because the length is quite big.
Yeah.
It's not one stent length.
Yes.
Plus there is
Dr. Shah, we have measured the length from that distal portion of the aneurysm to the distal end of the lesion is 38 millimeters. 38 would fix it.
So that is not covering the left main, right?
No. To the distal end of the, to the middle LAD, distal end of the aneurysm.
So obviously what I was saying is that you will require two stents, whether you cover without or with covering the ectatic segment or without. You will require two stents, that for sure.
Yeah.
Now the question is whether we go from the distal of that ectatic and then come from left main to the proximal of this. That's the question. I think the ectatic or the dilated segment is 4 millimeter, not more than that.
Yeah, that is 4 millimeters. Yeah, you are right.
Yeah. I think IVUS will make a lot of difference here if you can see the
That I
media to
agree.
media, in this case in the osteoproximal LAD.
I totally agree with you. Then probably what I would do is, if you all agree, I will do an IVUS to assess the left main size.
Left main and that ostium of the LAD, whether that can accommodate 4 millimeter or not.
Yes. So, and then I will do a DK crush.
Okay, fine. That's also fine. Now let's hear from Kirti, and then you can go off camera and we will go back to either Balbir or lecture. What do you say,
Balbir.
Dr. Kasturi?
Yeah, Balbir. We'll go to the Balbir.
Yeah, we have time. We have time.
You can comment. Are you able to hear, Kirti?
I can hear everything.
Yeah, yes, sir. You can comment.
Many comments have been made. I don't know what I'm going to add, but really, I don't think that that's an ectatic segment in the LED. That is not ectasia, even by definition, not by image. This is a 4 millimeter artery. And I think in that segment, you measured the lumen as around 8.32. And it looks like the artery is a little more than that. This is a large LED with a lot of plaque.
Little louder, Kirti, or close to the mic.
Can you not hear me? Can you hear me now?
Yeah, fantastic. This is good.
So there are a couple of things that I think differently about this. This is not an ectatic segment. This is a normal segment of the artery that you're seeing in the proximal segment after the osteoproximal area. There is a normal segment and then there's a second lesion. The question that I heard from discussants, where the question is whether you need to treat it as one lesion or you need to treat this as two different lesions, which means that do you need to separate your stents or you need to overlap your stents? I think that's the question that was initially asked. The way that the Syntax score defines its two segments or two lesions compared to one lesion is you look at this reference vessel diameter, and that clearly measures around 4.5. So if there are two reference vessel diameters between the landing zone, that means in this case, if there's a separation of the two landing zones by 10 millimeters, then they should be considered as two different lesions. Otherwise, it is just makes common sense to overlap the lesions and put in a stent starting from the left main going back to your mid LAD, because you've already done that. I think in my own practice, I would have determined the landing zones prior to balloon deflations, because then we can restrict our balloon dilatations to areas where we are going to stent. But I guess the entire area is dilated. This artery is still, I'm not sure if it is entirely and completely prepared for stents, because you have chosen a 3 millimeter balloon, which is your balloon which you've dilated it by. And I feel that I'm sure that's not the choice of stent that you are proposing to put in your proximal LAD, because your proximal LAD is close to a 4 millimeter artery. If I have to look at the landing zone in your in that slightly normalized area, if you look at the lumen is 3.8 and the artery is probably bigger than that. So your left main is likely to be 4.5. Your LAD is going to be 4. And so I think you have a large area. You need to prepare more. You need to show me that your 3.5 balloon at least is expanded completely in that ostium before I say that this lesion is prepared. For me, seeing a crack on OCT does not mean that the lesion is prepared. You have to expand it to your destination balloon size to show that that balloon expands completely. For example, in your mid LAD, if you think you're going to put a 3.0 stent, then of course your 3.0 balloon expanded. So that is it. But if you think you're going to put a 3.5 stent, then you need to expand it with 3.5 before you put in your stents there. As far as the question of the bifurcation, I see your point. Even though the diameter seems a little small, that OM is a very large distribution. And if you've had done a rotational atherectomy and if you have that recoil after a balloon dilatation, I have a feeling that a two-stent strategy, as VT suggests, would be my opinion as well. Yeah.
I think here osteoproximal LAD also significant. This is only, I think 15 mm segment is relatively disease-free, though the calcium is there, diameter is bigger, that beyond that 4 diameter segment is definitely more calcification, and there is evidence of fractures in the calcium block. So even if you put a short stent from left main to LAD, and I think it is definitely going to land, only leave the small area of the normal segment. I think better to cover the entire area, and DK crush, because LCX is very, very tight. I think it's very reasonably, very good area, a large area, and osteal segment is very, very tightly stenosed. And we should not ignore, because this is osteoplasm related. You can see there is a tight block and calcium and the dissected area is there. And even if you put a I think it will land halfway. So that's the reason, instead of leaving the small area, better cover that also. As Dr. Kirti Punyami has said, 3.5 upsize and adequate expansion. See how the block is behaving and do accordingly.
Gina.
I think shall we move on to the Dr. Gopal Krishna?
Yes.
Then I will go to Dr. Balbir Singh. Again, we'll come back to you. Meanwhile, you can.
Yeah, my plan is, actually, I did the distal reference diameter. We can show that it was 3.5. Yeah, that is that we want to do a 3.5 by 38 and then cover the entire with a 4 millimeter into the left main.
Yeah, that is the ideal.
For doing that, I will crush a stent in the to the LCA, LCX, then do a DK crush. That's the plan. Okay.
Yeah.
I would also spend a little more time. I would spend a little more time at preparing the osteomalady lesion to a furrow before you put in the stent, because it is very simple that you can then you would push a lot of plaque into the circumflex, which is at a narrow angle, and two, you need to not have an underexpanded
the audience
in that area. Anyway, that's it.
Ravi, we can.
Sir, we also have Dr. Neil, who has just joined us.
Yeah, you can. Now we will go back to Dr. Balbir Singh. Then again, last 5 minutes, we'll ask Dr. Gopal to show the remaining.
Yes, sir. We also have Dr. Neil Johnson, who has joined us, sir.
Yeah. Is he joined? So let me introduce Dr. Neil Johnson. Actually, he's working at Cardiovascular Disease Internal Medicine. That is McGovern Medical School at UT Health, USA. And as you all aware, he's very, very
chocolate
PCI. He has a lot of work in related to CFR. And with this brief introduction, he's also one of the main investigator in contrast and flow trial. And we are very much honored to have him as a panel member. And wholeheartedly, we are welcoming you, sir. You can join.
Thank you so much.
As the expert panel member. Thank you. Yeah. Hearty welcome to you. Nice to see you, sir.
Thank you so much. Good morning, everybody. Good evening.
Ravi, you can.
Sir, we already have Dr. Balbir sir with us.
Yeah. Dr. Bal.
So I will show you where we left. Can you go back on the images? So we had taken an OCT run before pre-dilation. Go back, please. Go back, 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 back. Okay, so we were here when we left you. So this was minus, go back. Okay, so we had done a pre-dilatation OCT run, which you had seen. And then we went ahead and dilated with a 3 millimeter balloon and repeated an OCT run, the LED. Run. So this is a much better image than what you saw. And Kirti was right that we had to look at the landing zones, particularly the distal. Proximal, we were satisfied. So this is how it looked like. Go back. We'll show you the distal landing zone. Go back. Go forwards.
We can't see the, now we can see.
Go forwards, please. OCT जहां हमने measure किया था ना, और जागे जाओ जहां हमने measure. Okay, so this was roughly the landing zone with a diameter of 3 EL diameter. This was in EL diameter. And you see a side branch coming, so the transverse diameter probably may be longer than what has been estimated. But clearly this was the landing zone distally. Go on, go forwards. And you start seeing the plaque and a small dissection there, a large plaque, which is a lipid and fibrous tissue, and then starts having some calcium now. And then there's a dissection plane, which was post-balloon, and you see a big dissection. And this is the tightest portion on the left main. We come close to the left main. This is the ostium of LAD. And we get to the bifurcation and the distal left main, which we saw early. So this was what we had. So the entire length up to the ostium of left main was 29.8 millimeter, 29.2. So we took a 3.0 into 33. So there was a discussion whether to take a 3.0 or a 3.5, because we'll have to expand the proximal part of the stent clearly with a bigger balloon. And our idea was to use a 4.5 balloon to pre-dilate that. So we were at that stage when we decided we take a 3.0, because I don't want a distal dissection, because if I cover another stent, it goes into that muscle bridge, which I clearly don't dislike a stent going into a muscle bridge. So with the idea that we could create a distal dissection which could extend into the muscle bridge, we took a 3.0 stent, because the EL was 2.9 to 3. So we took a 3.0 stent, 33, covering up to the left main. You see an ugly dissection on an angio. Do you see that angio picture?
Yeah, we can see that.
So there was a dissection. Now the question was 2-stent strategy or 1-stent strategy. So at this stage, I thought if I go for a 2-stent strategy, I'll mess up the whole dissection plane there with a decay crush particularly, or I use a mini crush. But I decided to go with provisional as the strategy. So we placed in a 3.0, 33 from left main to LAD, a crossover stent. Next, can you show the next? So this is the stent. So for the youngsters, it is important to understand that placing at the ostium of left main is important, because you will hardly leave any area, and you don't want to leave even 1 millimeter or 2 millimeter uncovered. And next, and this was carefully, the ostium was carefully planned to be seen in multiple views, including the cranial views, which are very important to look at the left main ostium. Next. So this was not well placed. Go back. Go next. Next. So having carefully planned this, and electrocranial was the last picture view where we thought this was properly positioned. Next. And it was deployed at 12 atmospheres. So we deployed the stent at 12 atmospheres. Next. Came back with a next. So it is fully, you can see the expansion was good. So that was some happy point for me, that the expansion in the LAD is pretty good. Next. Despite what calcium we saw. So we took a pot balloon, 4.5, left the jailed wire in the OM. This is the 4.5 pot, and tried to be as close as possible to the carina. And after that, next, we rewired the side branch. You can see that. So optimizing to the 3 millimeter and a 4.5. Then we rewired. The OM was flowing well. Next. Yeah. So this is how we rewired. So this is for youngsters to understand that we should first make a loop to go into the LAD, so that you are sure that you are not on the side of the stent. You have done a good, adequate pot, measured according to the size of the vessel, and then we crossed. Now the point was to look at where we have crossed through. Is it the proximal struts or the distal struts? And also to see whatever we have done in LAD and left main, is it adequate before we think of what is to be done to the OM? So we took an OCT run from LAD to left main, and we're going to show you that. So which was grossly inadequate. Can we have the OCT on the bigger screen so that it becomes more clear? Right. So we have the OCT run here. Can you run it, please? Yeah, fine. So we see the distal part is fine. There is no distal dissection. The stent is fully round in shape with reasonably good MLA. But as we come proximally, even in the transverse view, you can see the ostium of the LAD is not up to the mark. And if you look at the distal left main, I will show you the areas. And stop, please. So the distal left main area is not at all adequate. This is 5.8 and we are into the distal left main, clearly telling me that my 4.5 balloon did not reach that area. And the proximal LED also needs more work. So I got the 4.5 balloon again there. Now we'll show you the crossing of the circumflex. Can you show the 3D bifurcation? Okay, go forwards. Okay, so you see the cell through which it has gone is the distal cell, which is what we wanted. And it is a carina-free crossing. So this is quite satisfactory. So at this stage, the strategy was to optimize the distal left main stent, come down with a 3.5 millimeter on the ostium of LED. Optimizing distal left main stent means again a 4.5 balloon. Optimizing the stent in the proximal part of the LED with a 3.5 balloon. And then with a 2 millimeter balloon on the OM, do a final kiss. This is what final kiss followed by another pot. So this was the plan. So we have put in a 4.5 millimeter balloon and redone the whole thing, going carefully to the distal carina. The balloon was quite sticky, with which, as a result of which, the OM wire came out. So I'm going to rewire. So we have a lot of work to do. I have to do a kissing and also optimize the result further. This is where I am. So any thoughts?
Yeah, first of all, Balbir, excellent demonstration, and the most best part of it was that there is no malapposition, though there is under expansion.
Yes, right.
Okay, so distal wiring confirmed in that position of that wire, so that was good. Secondly, no malapposition despite taking a 3 millimeter stent and dilating up to 4.5. So that also is a good thing. Under expansion, now you can treat, do a kissing and confirm again on OCT and the bifurcation and everything. So which stent? You didn't name the stent. Which...
Okay, so 33 Zines, 3 into 33s.
Yeah, so 3 was expanded to 4.5.
Right.
And fortunately, no malapposition at that point, though under expansion. Right. So I think we are on the right track, and maybe your pot, you are going to do a pot kiss pot and then
so I'm
confirm.
going to do, I've already done the pot, so I'm going to kiss and do a pot.
And if you can do a side branch evaluation, that would be fine to confirm there is no dissection after the kiss.
Right.
And you have adequate lumen area also.
Yes.
Yeah.
So I would go more by angiographic appearance of the side branch, because pushing through the stent in the left main and crossing a side branch at a 90-degree angle with an OCT catheter can sometimes be not only difficult, but can also deform the stent. So I will be more happy to answer that question angiographically rather than looking at dissection. But the flow is STIMI 3, so I'm not too worried.
Yeah, right at this moment. So, Dr. Neil Johnson, your comments, and then Kirti, or Kirti first and then Neil, whatever.
I think it's a really impressive illustration of using OCT to understand how you cross back into the side branch there. And as you've already brought up, the technique, I think, is a nice demonstration of provisional. So I'm looking forward to the next couple steps, because I think you really outlined it well.
Right. Thank you.
I think my only concern is stretching a 3.0 balloon out to a 4.5, because you really, if you think that the distal left main had a considerable plaque which you need to cover and sort out, then when you start stretching these stents to 4.5 millimeters, you really significantly reduce their metal to artery ratios. And I would be concerned of significant plaque prolapsing through those very wide areas. That's one. We need to have a clear understanding of what size stent we need to achieve in the entire segment. And what I did not understand is just one part, because I'm not able to see any cranial view on the LED. Is there any major diagonal branch that is coming out from your stent segment area?
No, there's none.
There's none. Okay. None. Which means that you can then have a one uniform diameter with no major step down. The question is 3.5, and you've achieved an area of around 5.5 or 5.8 at that ostium of the LAD at the moment. Question is, how much, what is your target? Do you want, I would love to have a left main, an LAD ostium of at least a fully expanded 3.5, which is a 9.5. But we've got to 5.8. So what are you thinking? What are you thinking? What are you thinking in that sense?
So we have already decided that this ostium of the LAD is grossly undersized. We are not happy. So we first optimized the distal part of the left main, which is also deployed. You can clearly see the distal left main is also 6.8 or something, which is really bad. So I've already done the distal part. Now I'm taking a 3.5 millimeter balloon to optimize the ostium of the LAD, and then go with a 2 millimeter balloon into the OM to have a probably a good result there as well, so that we open the cells in that. We have a view clearly showing that ostium of LAD and the proximal part needs further dilating, and 3.5 would be the right choice. I have still not gone to that limit to expand it.
Perfect. And your distal landing zone is okay, covered well, and all that is okay, is it? Yeah.
I think it's a very elegant demonstration of optimization of DAS implantation, because achieving the adequate, like a MSA, that the distal left main still not adequately achieved, LAD not adequately achieved. Though angio may not show all those things, but the usefulness of intravascular imaging really helps in achieving, because every 1 square mm decrease the ISR rate by 11%. So bigger the better. So that is always better to achieve. And I think he has shown very beautifully. The OCT images are very lucid, and those pictures are with beautiful clarity. Dr. Balbir Singh, we will move on to Dr. Gopal Krishna. Again, at the end, we will come back to you for 5 minutes. Okay. Meanwhile, you can finish, sir.
Okay.
Okay. Then, Ravi?
We are moving, sir.
Yeah.
Elio call.
Yeah, welcome.
We are with Ayush Cath Labs.
Welcome, Dr. Gopal Krishna. Dr. Gopal Krishna, are you able to hear?
Two balloon though.
Ravi, not yet connected, I think.
We are connected.
Yeah. Are you able to hear me now?
Yeah. Okay.
Yeah, we did the 3.5 by 38 stent in the mid segment, and we post-dilated it to 18 atmospheres. That's what we have done so far.
3.5.
Yeah. Show the angiogram. Last picture. That is the picture. That is a 3.5, 18. We are planning to do the 4 by 15 in the left main, and whether we are debating whether we do a provisional strategy or decay crush, because we have to look at 86-year-old man with GFR of 55 and contrast with the decay crush technique and all those things. Hello? Yeah. That is only the additional thing we have done so far. So I think you can go back to the lectures, and whenever I finish, I will show you the result. Is it okay? Any comments, Dr. Kasturi?
No, absolutely very beautiful case. Actually, from the beginning, you have the rationale, the risk score system, and all those things you have described very nicely to understand. And strategically, that LAD disease and calcification you have shown very clearly after block modification. The evidence of fractures you have shown, the usefulness of the IVL balloon, though it's a long lesion, like a 20 pulses, 10 pulses, you have demonstrated the long segment lesion modification with IVL, and the L6 block modification with the ROTA, a very nice strategy. You can choose in either way if you feel that the steps are more, if the contrast is more considering the age. Even procedural static also is the preferred strategy. Decay crush, as you are very senior, you are also very well aware, and you are the right person to take the right call. And we are very happy with the case and really beautifully demonstrated. And final comments from Dr. V.T. Shah, Dr. Kirti Punamia, and Neil Johnson, and then move on to the Sir, you can comment, Dr. Kirtipunam.
I think there are others. Why don't you let Dr. Johnson and everyone also?
Dr. Neil Johnson, I think.
Yeah,
But I
Dr.
apologize. I kind of joined in the middle part of the case,
Yes,
but
that's the case.
Dr. Kirti, we did the 3.5 stent balloon and the ostium and it was inflated, that stent balloon. Go back. Go back. Go previous run. Previous. 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 Back. Next. Back. Forward. This is what we have done in the ostium of the 3.5 balloon. That what we have suggested, we did it. It looks like it is fully inflated. That is a 12 atmosphere expedition balloon.
Okay. So I think there's only one thing. This is, I think your most important decision is whether you consider this as a fully expanded. I mean, there's a small indentation, but I'm sure if you go at higher pressures, you can prepare it better. But the big choice that you will have to make is whether you are going to have your branch inclusive of your stent plan or your branch excluding the stent plan. The way I look at it is circumflex is not.
No, I'm not excluding the aneurysm. I am
You're going to stent it, right? You're going to stent the circumflex as well.
It's a 4 millimeter stent. Yeah.
No, the circumflex. Are you going to stent your branch?
The LCX, you mean?
Is it going to be a 2-stent strategy? I mean,
yeah, that's I'm debating. It depends on you whether you want me to go for that because he's 86-year-old. His GFR is 56 ml.
So
I've
the
used
question,
around 200 ml of contrast so far.
The way that I look at it is, if you were to lose that branch at any point in time by occlusion, and if it were to cause any kind of CK leak, or it is going to cause myocardial injury, then I think that significantly impairs it. It affects outcome. So that judgment call you have to make there, because being the operator, you need to decide whether you are going to take a chance with even transiently occluding that branch. And I think that is a very important call. I am a little more liberal, and I would go at any cost and save that branch, and I wouldn't want it occluded even for a small amount of time, and then try to negotiate it if they start getting ST segment changes. So that's how I look at it. But as Dr. Kasturi said, you are the operator, and I guess all of us can add a few little things, but the best man on the job is you. And I'd like you to make the right choice. Of course, you have to balance between being aggressive and smart. So,
one suggestion is, if you are going to leave and do a provisional strategy, then I would say you better do imaging of that ostium by whatever means to confirm there is no dissection before you stent from left main to LED. Otherwise, you can go ahead with 2-stent strategy, and then you did not do an imaging at this stage and maybe do it later on. So I think choice is yours.
Okay, thank you.
My only problem with that choice is that when you start doing imaging with OCT and all these branches, you add
IVUS can be done.
So if you have an IVUS, I mean, it is okay. You can take as many pictures and you can take as many runs with the IVUS, and you can still go back and interrogate it. But you also got to remember that when you start remaining in the cath lab for a long duration of time in elderly patients, then you are more likely to get into trouble. So you need to be quick. You need to make quick decisions, and you be smart decisions. Don't have to overdo things, but be smart and complete the case quickly.
Cutting balloon,
yeah.
Okay. Ravi, you can.
2.5 cutting balloon.
Ravi, you can switch to next lab. Sir, you can say final few words, Doctor. Yeah.
Sir, we are now moving to
Dr. Balbir Singh. 5 minutes we'll give time. I think then we will move on to the next session.
Kiran, can you get Dr. Balbir's lab, please?
Yes, I'm connecting with them.
Dr. Vitisha.
Dr.
We'll
Sridhar.
give only 5 minutes time, sir.
Yeah, okay. So
you can moderate.
Yeah, Balbir, are you through to the important
Yeah,
portion,
yeah,
or would you
yes.
like to get time?
No, I have finished, so I
Very
can show
good.
you.
So let us hear from you in 5 minutes.
Dikhao yaar, last. Go back. Go back. So you saw the wire crossing. We showed you through the distal struts, and I showed you how we crossed. And go back, go back, go back, go back, go back. So having crossed that, next. So we got in a 2 millimeter balloon into the OM. Next. So you see there's stenosis. We got a 2 millimeter balloon into OM, and the 3.5 for the proximal LED, which went to 20 atmospheres here where there's dilated. Next. Then pulled it back at the real ostium, another 20 to 22 pressure. Next. Dilated the side OM, which is looking already better now. We tried it at 6 and then pulled back both the balloons. Next. Then again dilated the LED. Next. Again the OM. Next. And then a kissing balloon, both at 10 atmospheres. Next. It looked that the OM could have taken a bigger balloon also, maybe a 2.25. But see, this is the result after the kissing. It looks pretty good. The OM is flowing very well, and the mouth does not show that severe disease. Having done that, now I'm taking a OCT final run. The pot after this. Next. Next. So this is the pot with the 4.5, back with the same balloon. Next. Next. So having completed that, it looks reasonably all right. So we are taking the final ariocaudal OCT run, which we'll show you. Start. Let's see how the measurements go. Angiographically, it looks very good. But I have left no more scope to do any more things because I have optimized according to what OCT wanted me to do. I did exactly what it was, imaging guided bifurcation stenosis. Next, left main. So look at the stent. It is so well expanded now. The proximal LED and the left main. And what Kirti pointed out was that these cells now look much bigger. And I have bench testing by Ormiston, and they have stretched the Zynes to 6 millimeter also. It's only the cells which will become bigger, and there is going to be likelihood of a plaque prolapse, but you don't have a choice. You have to do this case like this. But if you look at the expansion, and it's much bigger. Now, can we see the ostium of LED? Yeah. So it's about 9. So Kirti, if you are there, it's 8.7 from 4.5.
That's perfect.
So this is what we were aiming at, and everything was guided by our imaging. And now the distal left main is about 11. So which is what we were hoping. It was 6.4 when I left last with you. And with the OM which is preserved, I have no way I would like to do a tap there. And I don't want to do an imaging at the mouth of the OM because I have had bad experiences in the past. We can look at the 3D bifurcation view just to see how big the ostium looks like.
And stent integrity is very well maintained, no fractures.
Yeah. See, the mouth of the circumflex is open and reasonably all right. And I don't have any intention to do a tap in this. And I don't want to get an OCT catheter in it because I know in the past that it can create problems, particularly in such a small sized OM with 2 angles. Yeah, Sridhar, anything?
Yeah, so fine, fantastic, Balbir. That's the typical oval shape opening now with a Pottkey spot. And good expansion, good apposition. And the most important thing, the other thing I liked about was the demonstration of your kiss with the side balloon and the main branch balloon only overlapping at a short distance to avoid any kind of bottleneck effect, and plus very small the short snuggle type of case with the side branch balloon, so that you don't have any deformity of the stent at the opposite wall. So I think excellent demonstration of a provisional technique in the left main side branch section, plus that calcification seen on angiogram, which was moderately severe, but turned out to be of not much technical importance as far as the strategy was considered without using ROTA or IVL. So we got away with an NC balloon, not even an OPN balloon. So I think all in all, it was an excellent case. Nice of you to take all the pains, and your staff. Everybody, thank you very much for all this demonstration. And Barbil, congratulations to you for this excellent demonstration.
Thanks,
Awesome
Dr.
case,
Shah.
Balbir.
Thank you very much, sir. Usually, you have shown very complex PCA, that is bifurcation, OCT guided. Thank you, all of you, for contributing immensely for academic activity. And you can say final few words, and then we'll close this session.
So thank you, Dr. Kasturi. So the issue is that we always think that imaging is adds on to time, but look at this case.
Yeah.
The ostium of the LED looked the same as it looks now on angiography, and Kirti just pointed out that 4.5 on the ostium of LED is miserable. And I told you that I got a pathetic result, and so much little more exercise, and you turn around the MLA. So from 4.5, we got it to 8.9. And from 6.5 of distal left main, we got it to around 10, 11. So which is a huge difference in the outcomes and the MACE.
Yeah.
Which is very important to
Balbir.
understand.
Yeah, it's a very great learning case, because how the imaging helps achieving the MSAs, optimal MSAs, and optimizing test results. And definitely these results will produce the better long-term outcomes, like a reduced ISR, reduced stent thrombosis, because medial area, beautiful areas, like a 9 square mm, almost approximately lady, distal LMC, almost 11 square mm, very good areas. Thank you very much, sir, and congratulations to you once again. Then we will move on to the next session. I think Ajay is there, no? Ajay Swami joined, I think. Ajay.
Dr. Sridhar, good evening.
Yeah, good evening. Very nice to see you, Ajay.
Good evening, Ajay.
Over to you.
Good evening, Dr. Shah. So, Happy New Year, first of all, and always wonderful to meet up, even if it is on a virtual platform.
Okay.
My congratulations on a very nice, beautiful platform, and looking forward to what all we can see in the next hour or so. So, with your permission, we can proceed, Dr. Sridhar?
Yeah, you can proceed. You can announce expert panel members and speakers.
All right. So, good evening, everybody. I won't stand between you and our learning for the next hopefully 40 minutes or so, because we are running a little behind time. So I will request all our speakers to incorporate that into our deliberations. We have an excellent expert panel with Dr. Niels Johnson, Admiral Ravi Kalra, whom I had the pleasure of working with, Dr. Anup Agarwal, Cardiologist, Care Hospital, Banjara Hills, and Dr. V.S. Ramachandra and Dr. V.T. Shah, who are also there with us, and Sudhir Koganti, who happens to be from my college, so somebody of whom we are very justifiably proud. So Dr. Niels has already been introduced a little bit by Dr. Sridhar, and it's a great pleasure to be on the same platform as him. He has several clinical, he's presently Associate Professor of Medicine at McGowan Medical College at UT Health, and he has clinical interests which are as wide-ranging and diverse as they are cutting edge, with invasive catheterization, bypass surgery using non-invasive tools, modification like cardiac PET imaging, invasive tools like CFR, FFR. And he is one of the authorities on coronary physiology worldwide. Admiral Ravi Kalra has over 30 years experience in cardiology, and his career has spanned multiple generations with teaching experience of over a decade and a half. He served in INHS Ashwini Hospital, Mumbai for over 18 years. And he retired as the Commandant of Armed Forces Medical College, which was my own college, and the college that has produced so many brilliant luminaries over the last half a century. He's currently Head of Department, Cardiology Department in Bharati Vidyapeeth Medical College. Welcome, sir. Dr. Anup Agarwal, who is a diplomate in cardiovascular disease and diplomate in interventional cardiology, with 12 years experience in interventional cardiology with 5 years as a specialist. He's trained in the United States after completing his MBBS from All India Institute, and he's board certified for internal medicine, interventional cardiology, echocardiography, nuclear medicine, vascular interpretation, and valve interventions for aortic valve disease. Dr. V.S. Ramachandra, who is an experienced cardiologist in Hyderabad at Sri Holistic Hospital, is presently he was assistant professor at Nizam's in Hyderabad and is professor and head at Kasturba Medical College and trainer at Apollo Hospitals, Dhaka, Bangladesh. Dr. Shah, whom we have heard for such a long time over so many platforms, with over 2.5 decades of experience, consultant at Saifi Hospital, Surana Hospital, active in all conferences, with in-depth knowledge in treating complex coronary cases. Dr. Sudhir, who is a consultant intervention cardiologist at Citizen Specialty Hospital in Hyderabad, is an alumnus of the Armed Forces Medical College and pursued higher medical and super specialty training across various hospitals in the UK and has been awarded multiple times for his work. So we have 3 lectures today. Unfortunately, Dr. Rajesh has dropped out. Without any further ado, we'll request Dr. V.S. Ramachandra to start on the role of FFR for decision-making in multi-vessel disease.
Sir, Dr. Ramachandra sir has got some technical issues. So can Dr. VT Shah go, sir?
Yeah, I
Dr.
can
Shah?
go ahead.
Fantastic, excellent. So over the next 10-15 minutes, we'll look at post-PCI assessment of FFR for optimization. Dr. VT Shah. Sudhir, Anup, hi. Nice to see you. Happy New Year.
Hello, Dr.
Kalra sir, good evening.
So good evening, everybody. Can you see my slides and am I audible clearly?
Very much so, sir. Please go ahead.
Yeah. So good evening and thanks to Dr. Sridhar Kasturi and all our panelists to give me this opportunity to talk on a very exciting topic of post-PCA assessment by FFR and NHPR for optimization. And thanks for Dr. Neil Johnson to be here and listen to one of his favorite topics. And we would like to get his experts' comments after my lecture on this. So with the permission of Dr. Kasturi, I modified my title from only FFR and adding NHPR also for optimization. So let us go through this topic and I will take you through the latest advances in this topic. So first of all, let me clarify that there are many subsets to this topic, but I'm going to highlight only 2. The first is the evaluation of angiographically acceptable post-PCI result by FFR and NHPR. The second is evaluation of residual intermediate lesions post-critical lesion stenting. So that is focal versus diffuse disease and stenting. The rest, side branch evaluation after main branch stenting or the main vessel POBA to decide whether to stent or do it DEB in small vessels. And I am not going to include QFR, which is also a very promising evolving field whenever you are not doing FFR or NHPR, but you can do QFR to evaluate your end result. So I'm not going to discuss the bottom 3. I'm going to take you to the first. Long back in 2002, Pills had mentioned in his paper that FFR post-stent registry in his registry that there are adverse events at 6 months if the FFR is abnormal at the end of stenting. So long back in 2002, this observation was done. Then later on, there were many studies. One of them was in EuroPCR 2017, which showed that a relevant percentage of the patients of the stented vessels had FFR less than 0.9. And subsequently, we have many studies now which shows that post-PCI, almost the subnormal FFR occurs in 10 to 20% of the cases. So let me see, this is coming in my way. So, okay. So that is it. Right. Anyway, I have to get, okay. So this is almost like 10 to 20% of cases. Okay, I got my slide stuck. Yeah. There is another finding which we know now that recurrent angina at 1 year after PCI is present in 20 to 30% of patients. In many of these large trials, it has been shown. So is there a relation between an abnormal post-PCI FFR and the recurrence of symptoms of angina in the patients? So this is what we were looking at. And then we have found out, though angiographically you get a perfect result less than 30%, if you do FFR, then there is lot of mismatch between the PCI result angiographically and an FFR. So later on we found out that a post-PCI FFR of less than 0.86 versus post-PCI pressure gradient of less than 0.96. These are abnormal and this lead to long-term MACE. But what we also found out recently in 2020, that many of these resting PDPA abnormalities, when you do an FFR of this patient also there is a mismatch. So if you have 36-37% of cases with an abnormal PDPA post PCI, if you do an FFR, there are hardly 19% of that. So why is this so? And I'll take you through the slides and then we will see in what way we can implement this. So again, we have found out that as you take this abnormality from clinical chest pain to angiography and angiography at FFR, then at resting indices also, you will see that if you have this abnormal picture, then the end result changes. The more the abnormality, the more the MACE events post PCI. So one of the studies defined PCI, took such kind of, but only IFR was done. FFR was not done in this patient. And you see here that only significant lesions with an IFR of less than 0.9 was selected. PCI was done as per standard procedure, and then post PCI IFR was repeated. And these patients, of course, there were exclusion criteria like prior CABG, CTO, EF less than 30, associated valvular disease, and so on. And STEMI patients within 7 days, cardiogenic shock, arrhythmias, they were all not taken. So here what we saw is that angiographically successful PCI and qualified IFR pullbacks, 24% had less than 0.90 IFR. And if you see here, focal was almost 80% and diffuse was 20%. So a significant, almost one in 4 were abnormal, and large majority of them, the pressure gradients were focal, and which can be treated with additional PCI. And when we say focal, there were 3 types of focal. One is focal stenosis within the stent, which was like 38%. The focal stenosis proximal to the stent, which was like 31%. And there was focal stenosis distal to the stent. So that was also like 30%. Now, 1 year follow-up of these patients were done, and they were again studied in terms of CV death, MI, and target vessel revascularization almost at the end of 1 year. So what did they find? That they found out that the MACE rate was significant if the IFR was less than 0.95, as you see here, 5.7, and 1.8 if the IFR post-PCI was more than 0.95. So this was spontaneous MI, death, and clinically driven TVR. If you exclude the TVR also, then death and MI, that also was significant. So excluding that, that was also significant in this study. Right, so what did they conclude? That 0.95 is a very good cutoff for a post-PCI IFR to tell us to give a better outcome. So this was in a select group of patients only doing IFR. Now let us go to this subset where you have diffuse disease also. And as you see here, that a composite, the IFR is 0.64. But if you take the gradient was maximum at this place. And therefore, if you do a spot stenting at this place, then maybe you will get a normal IFR. So the decision lies between whether your abnormality is diffuse over period of the length, or whether it is focal, in which case you can do this focal stenting and get away with it. So, and with the advent of co-registration, this job is now better done and very well helped in day-to-day practice. So therefore, a future trial known as defined GPS has been taken with almost more than 4,000 patients, which has been undertaken, and we will see results in couple of years where angiographically guided PCI was done. At the end of it, if the result was satisfactory by that standard, then a IFR was done and this was blinded. Here, a IFR guided PCI, where if you get an abnormal PCI or PCI less than 0.95, then you see whether it is diffuse or whether it is focal, and then accordingly react and then give an end result. And at the end of 30 days, 6 months, 1 year and 2 year follow-up has been planned to find out whether a IFR guided PCI is better than angiographically guided PCI. Mind well, the selection of patients were all significant with IFR or critical lesions following an ACS. So now comes the trial which has used FFR, target FFR. So instead of using IFR, this study has taken up FFR as its, and it was a single center randomized trial, investigator initiated, and where what they did is that those patients who were having an abnormal FFR at the end of PCI were then treated further and then seen that whether you can achieve an FFR more than 0.90 and what was the outcome of that. So again, these were the standard exclusion criteria which I described you earlier, the same kind, and this is the flow chart. Now here, as you see here, there was a control group, post PCI coronary physiology, measurements were taken, results were not disclosed to the operator, and a follow-up was done. Whereas in the experimental arm, if the FFR was abnormal, they were further subjected to an angioplasty or whatever standard procedure was there for that lab, and an FFR of more than 0.90 was tried to achieve. And then this was also studied. If FFR was less than 0.90, as I said, further optimization by either balloon, additional balloon high pressure, or further stenting was done, and the procedure was complete. So, but despite all that, if the FFR was less than 0.90, it was left and followed up. So this was the PIOS, as they call it, physiology guided incremental optimization technique. So diffuse gradient versus the gradient cutoff was taken as more than 0.05, equal to or more than 0.05. So if you have a focal step up, you can either do balloon angioplasty. If you still further have, you can do a stent. If you have diffuse, you can do additional stenting. So now this is residual focal lesion with a gradient of 0.05. And as you see here, this is one example where you can see the distal lesion here. And then, so this is another diffuse residual gradient right from here to here. And then this is another under expanded stent, which was expanded and then treated. So this is an unmasked distal lesion, as you see here in this. So again, this was stented. So similarly, this treatment was given. Here, if you see here, there was a sudden jump and therefore this was also treated. So similarly, at the end of it, now if you see here in 1.5 years almost, there were these patients and they were studied. And if you see here results wise, that the more than 0.90 patients were 32%. Rest all of them, and FFR was less than 0.90. And look at FFR less than 0.80 was also 29%. Almost 30% did not achieve more than 0.80, which is our cutoff. And 0.80 to 0.90 was another 39%. So only 32% achieved an ideal FFR more than 0.90. So what was seen here is proportion of patients with FFR more than 0.90. After PIOS, it was 38%. Before PIOS, it was 28%. The difference was not very highly significant, but what was more important is that PIOS 18.6% and control 29.8 if you take less than 0.80 as the cutoff. So this was significant. Therefore, what it said is that in target FFR after angiographically guided PCI, 32% of patients had FFR more than 0.90, then rest did not have. Based on FFR pullback assessment, a substrate for further optimization was present in 46% patients randomized to PIOS, out of which 66% did achieve an adequate result after post-dilatation and stenting. So among these 40 cases, though of course the numbers are too small, but significant, mean FFR increased from 0.76 to 0.82 after your PIOS. And the other important thing was mean CFR, the coronary flow reserved, increased from 3 to 4, which was also significant, and we'll come to that factor. Now, as I said here, in the first trial defined PCI, it was IFR. In target FFR, it was only FFR. But this group of people from Korea, they did a wonderful study adding both the resting PDPA and the fractional flow reserve in patients with stent implantation. And this was a very good hypothesis which they had done to say that why is the difference between PDPA and FFR. You have done PDPA, as I showed in one of the slides, almost 39-40% had abnormal PDPA, but the FFR abnormality was only in 20% of the cases approximately. And why this was so? And this was explained by this reactive hyperemia. So here it is shown that after you have done balloon occlusion, and after that, if you suddenly open up this vessel, you get reactive hyperemia, and therefore your FFR decreases. So, and there they have said that your occlusion time also is important, and when do you do this FFR and NHPR is also important. And that is how they showed this in their study, that a post-PCI FFR, if you see here, there is a difference, significant difference between less than 0.80 and more than 0.80. Similarly, PDPA also had significance. So both are important. Now, if you see here post-PCI, sorry, yeah. So this the red bar, post-PCI FFR less than 0.80 plus post-PCI. So this is the group where if you see here that this is significant. If you take post-PCI, DPR and FFR both together, that is also significant. So you can take resting indices of either DPR or IFR and combine with FFR, and you will get a significant lesion. So here again, now this is very important slide which showed you that if you see here after stenting, after this focal stenting here, at the time at which the IFR is done, if you do at 1 minute, it is 0.84. You do at post-PCI 5 minutes, it is 0.88. You do at 10 minutes, it is 0.94. So you can see here the major difference. So whenever you do a PCI like this and you do these indices, you should give some time for the hyperemia to settle and give you a good FFR and a IFR. So as I said, caveat of post-PCI physiologic indexes, if you are doing post-PCI FFR, presence of severe microvascular dysfunction disease or transient microvascular dysfunction after PCI you have to consider. So give some 10-15 minutes for the reactive hyperemia to do an FFR. And if you have no flow, slow flow and things like that, definitely it will be abnormal, especially in an acute STEMI sort of situation or a thrombus lesion. Post-PCI, post-occlusion reactive hyperemia is induced by PCI, so it takes time. So your timing of measurement should be important. Use of post-stent ballooning, degree of reactive hyperemia, this will also affect this. So the key findings in this study was that 26% showed discordance between post-PCI FFR and PDPA. Both post-PCI FFR and PDPA showed prognostic implications. However, the reclassification ability for TAF was increased only with post-PCI FFR and not with post-PCI PDPA. Among patients with post-PCI PDPA less than 0.92, only patients with low post-PCI FFR showed significant increased risk of TVF, thereby meaning that if you have a PDPA resting, do a FFR. If the FFR is less than 0.8, it is abnormal and can give you worst outcomes. So now, very important and a provocative statement, I mean a hypothesis was given by this defined flow where Dr. Johnson was also involved primarily, and there they added CFR to this FFR. So what they tried to show is that if you have an CFR which is more than 2, but the FFR is less than 0.8, their outcome is non-inferior where the CFR. So this was at 2 years presented just now at TCT. A new observational study of deferred lesions following combined FFR and CFR assessments found that untreated vessels with an abnormal FFR but intact CFR do not have non-inferior outcomes compared to those with an FFR greater than 0.8 and a CFR greater than or equal to 2 when treated medically. So the next question is, do we now going to have a post-PCI defined flow study where FFR will be added to CFR also? So finally, coming to my last slide to try to show you that what you should consider post-PCI. This is an algorithm, simple to say that if you have a PDPA more than 0.96, PCI complete. If you have PDPA less than 0.96, you do an FFR. If FFR is more than 0.86, then nothing doing. If FFR is less than 0.86, you consider further optimization techniques and then either by dilatation or you can do an intravascular imaging to try and find out whether there is some under expansion, there is some plaque prolapse, there is something which is reducing the MSA and treat that or whether there are some distal or proximal dissections and so on. So take that help and try to sort out the problem. But at the end of the day, get a good FFR more than 0.86. Thank you very much. I'll stop sharing and then maybe we can have some comments. Good. Somebody stop shared.
Yeah, so I think that was a great talk, and you know there are lots of points for discussion. Dr. Shah probably knew that one of our speakers is missing, so I didn't have the heart to stop him. He was going so well.
No, thanks. So that's why I took some extra time to go through the slides. But Niels, first your comments now, most important.
Well, it got me thinking about the cases we were just watching, right? And one of the things when you do imaging is you always do a pullback, right? We wouldn't think of doing just a distal IVUS measurement or just a distal OCT measurement and stopping. We always do pullbacks. That's built into the way that we use intravascular imaging. And I think some of the notions that you brought up, and I think certainly the direction that it's going, is that to simply make a distal physiology measurement is also not using the tool to the best of its ability. And then adding the pullback information before PCI is incredibly important for understanding what you can expect after PCI, because the layout and distribution of plaque at the beginning affects not only what you do during the case, but also allows you to anticipate what you're going to see at the final result. And the types of vessels that respond best to PCI, obviously, are those that have very large focal pressure gradients in them. And it's a little bit humbling from the studies that you've shown how often that is not the case. And we can't pick the plaque distribution. Patients can't pick the plaque distribution they present with. And so in some ways, we do the best job that we can with the vessel that's in front of us. And it's a little humbling how much diffuse disease there out there is in the world. And that obviously ends up leading to target vessel failure down the road. I wish everyone had focal lesions. It'd make PCI an even more successful tool than it is.
So, Neil, question to you, is all this physiology study more applicable to the LED than to the RC and circumflex? And would it be that more important, because we all know that we are competing with the surgeons from Lima to LED?
You know, one of the key pieces for the LED is because it supplies a larger amount of myocardium for the vast majority of patients than the other vessels, is that because the mass is bigger, flow has to be bigger. And because flow is larger, then that generates larger pressure gradients. And those larger pressure gradients means that on average, if you look at big studies, you can see that the FFRs are lower in the LAD. Resting measurements are also lower in the LAD. And similarly, when you look at post-PCI FFR, kind of, for example, your target FFR data, the same thing applies, that the FFR values after PCI are lower in the LAD. And so I've taken that with to have the following clinical implications, and that's that I use FFR as a gray zone tool. So between 75 and 80, I put other data into my decision-making process. And what that's often meant is that for the LAD, I tend to push lower towards the 75 kind of end of the spectrum, unless it's a very focal lesion where I know I'm going to be able to get a great result. But you'll see so many LADs where you put the wire down distally, it's 7.6, you do a pullback, it's just completely diffuse. I would leave those types of vessels alone. And I think that is something that it would allow you to get good post values.
I just invite Admiral Kalra and then after that Anup for their comments, and then we'll come in with the last comments before we go to the next talk. I think he's not there. Anup, you want to add something before we go on?
You know, I think that this is a very apt discussion that we are having, because post-PCI optimization is absolutely crucial. And more and more we talk about imaging optimization, but I think the physiology optimization is equally important. And as Dr. Shah pointed out, that, you know, those cutoffs, while they are not quite dichotomous in terms of application, but certainly those numbers have to be taken into account in terms of what you are seeing imaging wise. And as suggested that if there are focal areas that you can optimize, you should certainly optimize. The position of the wire is probably very important in terms of where you are measuring, whether you are measuring immediately distal to the stent or 10 millimeters post stent, or you are measuring very distal in terms of what you are trying to achieve. And chasing the entire vessel is probably not the right thing to do. So those are my comments. I think that this is a very prominent thing that we should be talking about in our field. Thank you.
Great points. Just one more thing to add to the mix. I was very interested in what Dr. Neil said. You know, it's very important to decide what we're going to do with the patient on the table, and probably an assessment of prior to doing something as to what kind of a result we can give him. That needs to be part of the algorithm of what kind of treatment we can do. It was a really wonderful point. Just one more variable to add is I think we're not really looking at coronary microcirculation all that well. We're not very good at deciding what we need to do. We try to do some work with IMR, but there are so many insurmountable obstacles there. CFR is extremely variable and very difficult to interpret across all real life subsets. So there's a little bit of difficulty there. So it's extremely important for us to decide what we can do with this given patient and see whether we can do it well. And I think physiology has been grossly underused as far as cath labs across the world is concerned. We are so focused on looking at beautiful images and trying to get particular luminal areas. We sometimes forget that what we're trying to do is ensure flow down the coronary artery into the microcirculation where it really matters. Our ability to, you know, kind of look at the microcirculation, whether it has an influence in what measurements we're getting as far as our FFRs and DPRs and IFRs and RFRs are concerned, I think is a little limited. With that, something to think about. We'll go on to the next talk. We have Dr. Sudhir, who's going to speak to us on functionally guided revascularization in multivessel disease. And we'll come back to this interesting discussion with a little bit of time later.
Great. Good evening, Dr. Swami. And I thank Dr. Sridhar for giving me this opportunity. And I would also like to say hi to Niels. Much of my physiology, you know, in terms of interventional, you know, physiology, I learned it from, you know, the course they conduct along with Bernard De Bruyn and Nico Pels at European Heart House. I think I attended the one they conducted in 2016, which was a fantastic 3-day course. And of course, Bill Ferron as well. Over the next 10 minutes or so, I'm going to take you through how we can use, functional guided revascularization, functional information in guiding us in revascularization of multivessel disease. And I would also like to share some cases which I have used, functional information successfully. So myocardial revascularization is recommended to improve symptoms and clinical outcomes. Improvement in clinical outcome has been associated with revascularization of ischemic burden. The underlying ischemic burden should be assessed non-invasively or invasively. I think we should move away from this idea of stenting based on the angiographic appearance or eyeballing. FFR has unequal spatial resolution in determining ischemia, and IFR also provides good functional information with no need for hyperemia, and FFR-guided percutaneous revascularization, as we all know, definitely improves outcomes from all those pivotal studies. So what are the limitations we have from anatomic and non-invasive imaging? Assessment of severity by eyeballing has got its limitations. We tend to either underestimate or overestimate based on eyeballing. QCA can help, but not routinely used. People are not well versed with using this technology. And of course, it correlates poorly with functional significance. Echo, MRI, nuclear imaging achieve a sensitivity and specificity varying between 70 to 90%, and quite often we ignore the concept of balanced ischemia. There's many times when we do MRI with stress perfusion, which comes back as no ischemia, but when we do angiogram, we often find significant and important triple vessel disease. So this is a slide depicting the correlation between FFR severity and the stenosis severity. I'd like to draw your attention to the bottom left, where the angiographic stenosis severity is less than 70%, but FFR is significantly positive. So what role does it have, the fractional flow reserve in multivessel coronary artery disease? Multivessel coronary artery disease is defined by greater than or equal to 2 stenosis in 2 or 3 major epicardial coronary arteries amenable for stenting. And routine use FFR results in better PCI, alleviation of symptoms, improved outcomes. We tend to use less number of stents, and of course, cost reduction to, as I'm going to show in this next slide from Bill Ferron, where FFR fares better in terms of quality, and also it's cheaper in terms of, when compared to angiography. So this is a summary slide of the pivotal studies from early years, going from DEFER to FAME and FAME2, where we clearly shown that FFR-guided intervention improves outcomes in the long run. And then there is IFR Sweetheart study, which again showed, IFR is non-inferior FFR, and across both the arms, more than 40% had multivessel disease. Coming to Syntax 2 study, again, 75% had functional assessment, 30% had reclassification of the severity of the disease, 25% had deferral of the PCI, and 85% had multivessel disease. And the evidence is there in STEMI as well, which came from the Compare Acute study published in 2017, where the non-infarct related artery, when it was intervened based upon the functional information, it led to better outcomes. And as you can see here, also led to less revascularizations. And we have data in NSTEMI 2 from famous NSTEMI, done by Keith Oldroyd and his colleagues from Scotland. FFR was measured in any stenosis that angiography was greater than 30%. So this study has shown that we can use this technology in non-ST elevation MI patients. And it was also shown angiography-guided management was associated with higher rates of coronary revascularization compared to FFR-guided management. And lesion severity, again, was reclassified in almost 21% of the patients. So this is a summary slide showing the decision, how the decision changed when the functional information was factored into. It's almost 26% change in management plan post FFR. So likewise, there's evidence from the Ripcord and Ripcord FR CT study led by Nick Curzon and colleagues in England. Again, there is reclassification based on the functional information. So what about coronary artery bypass grafting? So as I've shown, we have pretty much evidence in each and every setting. When it comes to CABG, graft patency is affected by multiple factors. The severity of angiographic stenosis of native coronary artery impacts graft patency, and competitive flow, intermediate stenosis all have a role in graft occlusion. The computational fluid dynamic studies thrown insight into interaction between anatomically noteworthy stenosis and poor perfusion post-surgery. Physiological assessment of multivessel disease appears to meaningfully impact grafting strategy. So Gebert Toth and his colleagues from Italy looked at did a retrospective analysis from their cohort, and essentially they've shown by using FFR, we tend to use less number of grafts, lower on-pump surgery, lower graft occlusion, and lower event rate and lower rate of angina too. However, this is a great concept, but the whatever we were using to achieve good results for for our CABG patients have served as well thus far. So more data is needed, and it is underway in CABG decision making regarding CABG versus PCI. FAME3 is currently being enrolled, and then there's Graffiti, where graft patency after FFR guided versus angio guided CABG trial is undergoing, and then there's Fargo, in which FFR versus angiographic randomization for graft optimization is also enrolling. So with that background, I'll quickly take you through a few cases. The first is a 68-year-old gentleman with exertional breathlessness with a background history of diabetes, hypertension, and being a smoker. His CT chest showed a lung mass, which is highly suspicious for malignancy, and it also shown a significant coronary calcium along with carotid disease. He came to me for surgical clearance with a background of good LV function. Given the equivocal symptoms, risk factors, and CT findings, I took him for an angiogram with a view to intervene only if I have to, and that too by using a stent in which we can stop DAPT early so that he can have this important surgery for his lung cancer. So this is his angiogram. We can see this mild to moderate stenosis in the circumflex artery, and again, same mild to moderate disease in the mid LAD disease. See, I'm already saying mild to moderate because I'm not sure, how severe the disease. Another view showing the LAD disease. And then there is a right coronary artery, which angiographically, we would all call it significant. So I proceeded with the FFR of all three arteries. And the readings are as shown. RC8 was 0.85, CIRC 0.99, and LAD 0.89. So I deferred any intervention. He underwent tumor resection with no issues, followed by radiotherapy, and remained symptom-free to date on optimal medical therapy. So I'll take you through another case. 64-year-old female with a background history of diabetes and hypertension. She's got recurrent pancreatitis, and most recent admission was due to non-ST elevation MI. So I took her to cath lab, but again, I was cautious in terms of what I'm going to do, given her background history of recurrent pancreatitis, in case if she needs any sort of intervention in the near future. I'm sorry about this. So again, she's got LAD stenosis in the mid segment that looks moderate, and a diagonal osteoproximal diagonal that was significant. So I did the FFR to LAD, which was 0.84. Following this, I did a drug-eluting balloon to diagonal, and then did FFR to RCA, which was 0.76, and she had a biofreedom stent to the right coronary artery. And my worst fears came true as she presented early, within a month, or just on the cusp of the 30th day after the PCI, with another acute admission requiring a lot of procedures, and I was able to safely stop one antiplatelet for her. So I wouldn't have gone with biofreedom had I had to intervene for both LAD and RCA. So I'd share one last case before I wind up. And this is a 67-year-old female, background history of diabetes. She had an angiogram in 2018 where the report stated LAD had 50 to 60% stenosis. She presented with chest pain followed by syncope with localizing changes on ECG to LAD territory and with a troponin of 0.01, which is negative, essentially, in my setting. And again, this is her angiogram, where you can see that mid-LAD, she's got what probably would fit with that 50 to 60% stenosis mentioned from the previous angiogram. So I did an FFR, it was 0.69. So proceeded to PCI with one drug-eluting stent with a very good result. And she's doing well. So in summary, multivessel disease is common in clinical practice. Routine functional assessment will lead to different management plan and improve outcomes. Routine functional assessment will result in less expenditure. I'm not so sure about this. In Indian setting, we haven't got any data, but we can debate it later. And more data is needed for CABG, and it is underway. Thank you very much.
Excellent, very nice. So I think Dr. Kalra had to leave, so we'll first go with Dr. Johnson, and then Dr. Shah, and then Dr. Anu. Yeah. Dr. Niels Johnson, can you hear me?
Yes, sorry, the volume was a bit down there for a moment, but yes, I can now.
Please go ahead. Please go ahead. Would you like to open the discussion and we'll take it
Yeah,
forward.
you know, it's interesting. There has been a study on the cost effectiveness of fractional flow reserve from your country. You're right. The challenge is that because stent costs in your country have been fixed by the government at a very low level, that obviously changes the cost effectiveness equation. This was a study that came out last year in CCI, and the conclusion was that, I'm just reading it here, FFR guided PCI is safe and cost effective even in the Indian setting. So there actually is some data now looking at, there's a study of maybe 400 patients, 500 lesions, and use microcosting analysis to look at FFR. So there's several publications now. Almost every country is doing its own FFR cost-effective analysis, because you're right, the local healthcare system is going to change stent costs, wire costs, cost of medical care, and subsequent follow-up procedures. So I find it interesting that even your healthcare setting, it seems as if it's a reasonably cost-effective option to do physiology. Great cases too, by the way.
Thank you.
Yeah, so but Ajay, can I ask a question to Dr. Neil Johnson?
Sure.
Yes, sir. We'll allow Dr. Anup to respond, and then you can ask your question.
Yeah, please.
Thanks, Dr. Ajay. So I think this cost issue in India is very tricky, because whenever we do the cost analysis, we look at the overall system cost analysis, versus in India, it always boils down to the index patient cost analysis. And there, when you look at adding more cost to that index case, then that cost analysis becomes, that dynamic is much different. So if you have a third payer system or three-party payer system, then for that third payer, overall, if you do 100 cases, then overall the cost to the system will certainly go down if you use a functional assessment-based intervention that has been shown in multiple settings like United States and even the Indian setting that Dr. Johnson is pointing out, where it is not a patient pay model versus in India, where we are looking at that index case. So I certainly agree with the idea that overall cost to the system will be more effective if we use a functionally guided. In out-of-pocket model, it becomes a little bit challenging to implement that.
I've been a really strong proponent of physiology, and I find it very curious that all our cost discussions are centered around physiology. We really don't look at imaging as a cost. If you look at the cost of imaging and the cost of physiology, the cost of physiology is probably a fraction of what it would be. It has a far larger evidence base than imaging ever has. You could arguably do 90% of your cases in the lab without imaging, even in today's date. whereas physiology actually is going to add to every single case that one does. And I find it very curious that we have these discussions on cost when we should be looking at morbidity and mortality. The power of reduction of physiology-based intervention is far superior. There's no argument about it. Imaging still has a place in certain particular situations, definitely. But it's the power of marketing that one looks at work in in various scenarios. So I find it very curious. Please go ahead, Dr. Neil. Dr. Shah, you wanted to ask Dr. Neil?
No, I wanted to ask Neil one question. In multi-vessel disease and you are doing FFR, would there be a preference of which vessel to interrogate first? The most critical which you look on angio, or you look at the most one which doesn't look most critical?
I tend to do it in sequence of how it's going to change what I do clinically. And often many of the cases come down to a choice between bypass surgery or PCI. So for example, imagine you had, osteal left main lesion and an RCA lesion. And for me, I'd say, well, okay, let me do the LAD first. And maybe if it's positive, then we'll take the patient off the table, or at least have a discussion about how to manage this, or a complex bifurcation or something like that. And if it's negative, great, I'll flip over, I'll do the RCA. If it's positive, I'll just stent it right then, because I already know what the other vessel has done. So I try to think a little bit ahead about, okay, let's say it is negative, let's say it is positive, how am I going to plan the rest of this case strategy? That's how I tend to do it. In some cases, there's no difference, and it just whichever is easier.
Great. I'm so sorry to interrupt. I mean, I was looking forward to sharing this discussion. We have another talk, and Dr. Ramachandra is now able to join us. This is the role of FFR for decision-making in multi-vessel disease. And I stopped the discussion because I don't want to tread on his toes. So Dr. Ramachandra, please go ahead. Ravi, can we get him? I got a message that he's available.
He's already with us, sir.
So can we start?
Dr. Ramachandra, sir, can you unmute yourself? So we can see you, sir. We have your presentation also, sir.
Yeah, thank you. Sorry for the delay. Actually, there's a slight problem with my laptop, and I changed it a bit because Sudhir already talked about multivessel PTCA. So we'll just go through some case presentations here. This is a former CEO of a large hospital group, and he was actually advised triple vessel angioplasty with lesions in his LAD, mid-RCA, and stress may be showing ischemia in inferior and anteroseptal areas also. And as you can see, he has a prox LAD lesion that's slightly hazy, and then there's a tight LCX lesion and a RCA lesion that has distal as well as mid narrowings. So because this was the tightest portion, and we went ahead and stented the LCX because we thought it was more than 90% and really did not necessitate a FFR there with reasonably good results with no pinching of the OM. And then we did the FFR for the LAD, which was non-significant. I think it was, and then we went ahead and did the FFR for the mid-RCA, which was also non-significant. So thereby we avoided a multivessel PCI in this person. And then after a few years, I think after 3 or 4 years, he again came back with chest pain. And this time his RCA lesion, his mid-RCA lesion had increased. And we stented that lesion because it was anyway a case of unstable angina. And his LAD lesion, which was proximal and more difficult to tackle, was the same. So I think we have very good data on FFR for prox LAD lesions. There's a specific study for prox LAD lesions, and even at 5 years, those who were FFR negative continue to do very well. So some people have this problem of of relying on FFR for distal LMs as well as prox LADs because they think they are dangerous anatomical locations, but the FFR holds good even in those places. So yeah. So we had actually we had a similar patient to the previous one who had acute coronary syndrome and a similar triple vessel disease. Actually, it was very difficult for us to find out which was the culprit lesion. He had a LAD lesion of around 80% and a right coronary artery lesion which was slightly hazy looking and around 60%. So we did FFR for both these lesions and then stented the LAD because it was anyway quite tight and the FFR was strongly positive, which means less than I think 0.73 or something. And the RCA was good as far as the FFR was concerned, and we left him. And 3 months later, he came back with a syncope, and his RCA had closed. And his first symptom also was syncope, which makes me suspect that his initial drop positive lesion was his right coronary artery and not his left anterior descending. So this is one thing that we have to be careful in acute coronary syndromes. Your FFR may not hold good, which means FFR might be normal. But if you miss a ulcerative plaque or a ruptured plaque, which was the culprit lesion, then you have problems. So in multivessel PCI, if the culprit lesion is very clear, then there's no problem. But if the culprit lesion is not clear, then we have to look at the clinical scenario. In this patient who had syncope, I think we should have thought that his RCA could have been the culprit rather than the left anterior descending. So this is a very important point when we look at the clinical scenario. This was another patient similarly with a right coronary artery lesion. As you can see, it doesn't look very tight. His FFR was also normal, and similarly he also came back. His troponin was also positive, and he came back with chest pain and symptoms later. So basically, if in acute coronary syndromes, you cannot rely too much on the FFR, especially in multivessel disease. Now, this is also where we can use FFR. As you can see, this person had a stent in his left anterior descending, a large mid-LAD stent around 3 years ago. He came back with an increase in the lesion just proximal to the stent. So we did a FFR because we don't have IFR. We did a FFR at those two regions. This was strongly positive, I think around 0.73, and then pulled back and did proximally, and that was good. And not very evident on these angiogram pictures is his ostial LAD also had a 50% narrowing, and because the FFR distally was positive and proximally was negative. So this was the proximal FFR and this was the distal FFR. So we just had to stent the distal lesion and left alone the proximal lesion. So this is something very important, very useful in using FFR is when you have multiple lesions with FFR, you can check at multiple points. So they're very close. Usually clinically, it's a very easy decision. If there are multiple lesions and you have a case scenario like this where FFR makes it very clear which lesion to stent. Now this is another person who had a lesion like this in the obtuse marginal, and as you can see here, this person had exactly the similar lesion around 5 years before. It was negative this time also, and both times his stress nuclear, his stress maybe is positive in the inferior and posterior regions corresponding to this area. This is a very peculiar thing, and I think a lot of cardiologists must have seen this, that they get more false positive results on a stress maybe distal to a lesion that is intermediate and that is negative on FFR. So I think if you can measure CFR or IMR, then you would know that there is some problem in the distal vasculature, in the microcirculation probably. And these microcirculatory problems are more common distal to intermediate lesion than in normal coronary arteries, which means along with an intermediate lesion, something happens distally also. This is why you tend to get sometimes a stress nuclear which is positive in a particular area, and that is subtended by a narrowing, but which is negative on FFR, and these people do well with medical management. So this is another case where you have a multivessel disease. As you can see, this person has instant stenosis in his right coronary artery and a seemingly tight lesion in his left anterior descending. So many people would ask, which one would you do FFR first, or which one would you stent first? And this man's FFR in his LAD was around 0.75, 0.78, somewhere near 0.8. And but because it was subtending a large area, it was giving collaterals to the right coronary artery. We stented the right coronary artery first, and then did the FFR of the left anterior descending artery, and then it was around 0.93 or 0.95. This is also very important to see what area of myocardium that particular vessel supplies. If it is supplying collaterals to another area which you can stent, then you are, once you have stented that collateralized area, it's important to check the vessel that was the feeding vessel. And once you have restored flow to the other vessel, this vessel's FFR might become normal. So this is a very important point. I'm sure if we had not opened up the right coronary artery, we would have landed up stenting this left anterior descending, which most probably does not need an angioplasty. FFR is also very useful in patients with sometimes you see huge calcium and then multiple hazy looking lesions, especially in the elderly people. And this is a person who many times what we do in these people is we initially do a stress MIB, because we do not want to put the FFR wires, especially if you are reusing these wires down into multiple arteries. So we do a stress MIB, and then depending on the stress MIB, depending on the artery that the stress MIB shows positive, in this case the RCA showed positive, and then we did the FFR for the RCA, and that is normal. We can just medically manage them. So this is also very important aspect of using FFR in multivessel disease. Like you can do a stress maybe in them, or you can do multiple FFRs, and if they're all negative, you can just keep them on medical management. This has also been proven well in studies. So the main thing what I was referring to is the disparity between the other stress tests and the FFR. As you can see, the FFR is basically measuring the lesion. And if you rationally look at it, what it tells you is that there is a flow limiting lesion. And once there is a flow limiting lesion, the flow itself most probably causes progression of the lesion. And that's why how the FFR is helpful in predicting progression and further blocking of these arteries. So once the FFR is negative, it basically means that the lesion is not flow limiting. So the hemodynamics there will not cause further progression of that lesion, and that lesion will be stable. So the other modalities basically look at whether it is the CFR or the IMR. They look at the whole picture. So ideally, if we have good measurements for FFR, CFR, and IMR, then it would become easy. But lacking those technologies right now, I think FFR is the best way and a much better way to look at these lesions than stress maybe and other ways to look at ischemia. As you know, there's a very large segment of acute coronary syndromes as well as ischemic lesions that are subtended by non-obstructive lesions. And that is why you have these studies, the ischemia trial as well as trials like the Courage, that give you results like that as if you can ignore ischemia. But most probably many of these lesions by themselves, the lesions themselves may not be ischemic, but the artery, that the myocardium, that the subtend might be ischemic, because if you look at FFR trials, all of them consistently, except the future trial, all of them show that you can rely very well on the FFR on the long term also. Coming to, there's a last trial called the Orbita trial, which actually looked at double randomized FFR positive patients. And very peculiarly, as you can see, although it improved ischemia, the symptoms did not change much in these people as far as their effort tolerance was concerned on the treadmill, which means you cannot really depend a whole lot on symptoms in some people who are FFR positive also. And this has been nicely documented in the ISIS registry, where after this, the guidelines say that you can stent even asymptomatic non-ischemic, which means there is no ischemia on other modalities. But if the FFR is positive, then you can stent that lesion. So which basically means FFR is such a strong tool that you can predict even non-symptomatic lesions, how they would progress. And the last slide is how you would look at multivessel disease. See, multivessel disease is not just ischemia, you got to look at the LV function also, because where there is hibernating tissue or where there's loss of myocardium, FFR, even FFR might be normal, although the lesion is quite severe. So, and you need to look at the anatomical burden also, like left main, proximal LAD, especially in a case like a person has proximal LAD lesion plus LV dysfunction. So you would need to look at all these three things while looking at whether and how you would revascularize a multivessel disease. Thank you.
Yeah, actually, in the interest of time, we'll move on to the next session. I thank Dr. Ajay, Dr. Neil Johnson, Dr. Ramchandra, Dr. Anup Agarwal, Dr. Sudhir Koganti for contributing immensely to this academic program. Because already we are running short of time, almost half an hour delayed. So then we'll move on to the next session. As you just say, Ajay, final few words, then we'll announce the next session.
Excellent, sir. Really enjoyed the last half an hour. Thank you to everybody. As Dr. Sridhar said, I think we had a very nice session in which we looked at how to look at physiology in multiple situations, in patients with multivessel disease, in patients with microvascular disease, how physiology can add to the results that we give to the patient at the end of the procedure. The importance of post-PCI physiology was emphasized by Dr. Shah. And thanks very much to all the faculty, Dr. Neil especially, for giving us a special insight and his special, the benefit of his expertise in this particular situation. Thanks, Dr. Sridhar. Please go ahead.
Thank you. Next session is image-guided complex PCA, case-based presentations. And now I would like to request expert panel members, Dr. Jabir, Dr. Arun Gopi, Dr. Sushi Mahanti, Sushin Malani, Dr. Arun Kalyan Sundaram is there.
Yes,
Dr.
and we also have Dr.
There. Yeah.
Vijay Kumar Reddy and Arun Kalyan Sundaram, you can coordinate the program. And we have a few presentations. Dr. YBC Reddy is there. I'm able to see you. Very nice to see you, YBC. And Dr. G.R. Harish Mehta, Dr. Lakshmi Khan, Dr. Shiva Kumar.
Yeah, we also have Dr. expert.
Arun, you can continue the proceedings.
Sure. First of all, welcome everyone. Thank you, Dr. Sridhar, for the kind invite, and it's such a great thing to be part of this. I know we are running late, so I don't want to go on and on. This is going to be a feast, so I'm going to invite Dr. YVC Reddy to give the first talk, and then we'll kind of have the discussion towards the very end.
I request everyone to stick to the time. So just because already we are running half an hour late.
Yeah, that's very important. Hi, Arun. Good evening, everybody. Dr. Kasturi, good evening. And I think we should start straight away with the first case presentation, please. Yeah.
Yeah, absolutely. Yeah.
Good evening, everyone. I hope you can hear me. I'm audible. And hi, Sridhar, Arun, and all my friends there. It's a small, just a snippet of a case presentation. We all know the prophetic belief of Forsman and the great work, the diligent devotion of all the trio led to this great serendipitous discovery of coronary angiography. And I consider this as the most wonderful, amazing imaging technology available for us. And of course, this coronary imaging technology has led on to CABGs, angioplasties, and whatnot. And now we have the IVUS and the OCT imaging as well. This case is about a 54-year-old male, no risk factors, 2 weeks of effort dyspnea, a chest physician who sees him as normal, does all the tests, and a positive treadmill pushes him to our unit. And then this is the angiogram. Like all imaging modalities, IVUS, OCT, or angiography, acquisition, analysis, and action, all the 3 A's are very important. And probably in angiography, the acquisition is even more important than the other 2. So this is how the angiogram looks. And the interpreter, the interpretation, and what is being interpreted. That is the triad of the importance in angiography, like in other imaging. And we find there is something happening in the LAD there. I think if you can look at the LAD, you know the answer. It's not just in one area, in multiple areas. Again, in some other angle. And of course, classically, we say in medical heuristics, it is not just what you see, but what your mind has already interpreted in terms of your previous knowledge, and that disease is there, and there is something over here as well. So this is the clue there. And then you take appropriate views because you know it, and then the reality is glaring there. This is the obvious diagnosis for anyone who has seen these pictures before. So as the dye goes, we get the diagnosis, we know it, it splits, the dye is splitting into multiple channels there, and then forms a disease pattern here. So how the dye clears also is very important. You can see it very well. I'll just go through this. These are very important to analyze the way the dye goes, because finally, this is the angiography imaging is the technology where you enter using your guide wire to navigate into the true lumen below. So this is the classical appearance you have seen there. And there is something happening in the apical LAD as well. This is again a telltale sign of what the disease process is happening upstream. In multiple views were taken, and this is what the apical LAD is. So he goes in for a radial PCI, 2 weeks history of angina. Of course, a fine cross, XB3, Fielder XT, the usual navigation techniques. We have analyzed the way the dye is flowing, and then you enter it. Of course, we are going to use an imaging. Again, adjunct to imaging like OCT serves 3 purposes. One is to help the interventionist to achieve better results. Another, of course, is learning. And third is to teach others. And probably in this case, I think all the audience, all the colleagues there know about the diagnosis, obvious, and angio itself. But probably for teaching, it serves a purpose. So BMW wire was exchanged. Then an OCT run is done. And this is what it shows. If you look down here, even before the main lesion starts, the vessel is okay, the fibrous plaquing is there. And then you notice something interesting will happen. Well, slightly distal to the lesion itself, some neovascularization there, and then some intimal break, an intimal break, and then intimal break, intimal breaks. And then, of course, the real disease pattern here. The classical so-called Swiss cheese or lotus root, multiple septae, hyperechoic, multiple communicating channels, all that is there. And then, of course, deeper, it is very, very dark. And then the branch diagonal comes, and then rest of it looks normal. So this is the classical old recanalized thrombus, Swiss cheese or spider web or whatever name you call it. Probably aptly we should be calling it a Swiss cheese. It's not as symmetric as a lotus root. Spider web, it doesn't look like a spider web, but the importance of a spider web is if you use your wire in a wrong technique, then you can land up in a spider web scenario. The characteristic feature is this bright, high backscattering signal-rich septations and multiple channels. And so these channels will be coalescing later into the distal normal lumen as well. The deeper portion, of course, as you all know, is proteoglycan, so you have darker tissue there. So of course, the old recanalized thrombus, if you put one level ahead and then think why it happened, it could be a spontaneous coronary artery dissection, which I personally think is the commonest cause of a old recanalized thrombus like this. A plaque rupture or an erosion causing thrombus usually will not lead to a recanalized thrombus like this. And as in our case, let us see what has happened here. You can see distal to the lesion here. You can see well below the intermedial layer as it disrupted. There's a spontaneous coronary dissection flap. Still, in some areas, the dissection is seen there. And you can see that happening. And this honeycomb, the spider Swiss cheese is happening outside the intermedial borders itself. So this explains why this is a SCAD with recanalized thrombus. The thrombus must have happened. On going back into the history, he admits to having had an episode of severe chest pain 2 years back, which he came out through after suffering for an hour or so, and he never even went to a doctor. And now for 2 weeks, he has been having this unstable angina. And why does it happen? Again, if you see the thing, we know that there are some areas where there is a thrombus, a fresh thrombus can be seen there. You can see some thrombotic, if some of these microchannels are the recanalized spaces, get a fresh thrombus, here a red thrombus is seen there, a white thrombus is seen here. So these can add to the component and convert this classical stable scenario into an unstable ACS presentation. Many of them present to us like this. Of course, you can see that the 3D mode might not add much except to show that it's all a shattered appearance in this area with multiple communicating channels. Proximal and distal, of course, will be a single normal lumen. The same thing you can appreciate in bifurcation mode, just to show that the angiographic imaging, if you see the longitudinal view of the angiogram, a dynamic component, which is the most beautiful part of the imaging, and the same longitudinal view of the OCT as well, you can appreciate the same features over there both. But then the beauty of the OCT is in the axial views, which as an angiographer, you will have to rely on your third eye or the mind to construct these short axis views in multiple orthogonal planes and then go ahead with a good procedure. Of course, you can get the reference diameters. Procedure is quite simple. A little bit of pre-dilatation just to make sure the septa are not too resistant. Stenting with a 422 drug-eluting stent. Post-stenting run. Post-dilatation to 4.5 in the proximal part only. And then a post-stent OCT. So can notice, of course, optimization can be verified here. As you come to the stent over there, you could see the well expanded stent, well opposed. You could see some tissue tags of the thrombus prolapse, a small component there. The rest of it is very well expanded. So I will just take you to the proximal side is good. But then if you concentrate over here, just distal to the stent, you can make out what was a small dissection flap there. So this is not uncommon in cases of SCAD leading to recanalized thrombus scenario. It will be quite delicate there. So here the MSA was 9.93, opposition indicator is quite good. That was a diagonal branch over there in the red line. The thrombus or tissue prolapses, not of much consequence, but the distal edge dissection, yes. You could see that the arc is more than 60 degrees and the length of the dissection more than 2 mm in the longitudinal view as well. So of course, this needs attention. So we just put up one small 3.515 stent. And again, the overlap area, again, go with a bigger balloon. And that's the result. And as we said, this is the distal apical LAD. You can see that appearance there. This is actually a heel SCAD again lesion and some extra classical typical luminal dye is still seen there. This is the classical SCAD telltale signs of the sequelae. Of course, we didn't go for imaging there and we don't need to do anything at the apical area. So what is known about this? We know that the histopathology has been correlated. Everyone knows about these appearances, how these septae look. This is how the SCAD with old recanalized thrombus looks. Some of the cases, the SCAD can be appreciated in as a linear flap, but if it's a spiral dissection and it is shattered like spiral dissections, the thrombus that forms on these shattered spiral dissections, that is what usually heals and recanalizes in the way like in this case. It has been reported in polycythemia vera as well, this type of scenarios. You might get a thing like this, or the telltale signs will be there. So in conclusion, old recanalized thrombus is a typical appearance in angiography, IVUS as well as OCT. Once seen by an angiographer, this appearance, whether he has seen it on his own cases or in the literature, anywhere, it is very easy to detect it, know it even by a simple coronary angiography. OCT with superior resolution gives spectacular images, especially the axial views. It can bring out the subtle nuances like the underlying cause for the old recanalized thrombus, like SCAD, quite well compared to angiography. In this case, of course, teaching is a very useful benefit of the imaging. It also helped in this case to show the distal edge dissection, which needed attacking. And of course, third eye needs to be used for all professional work. Every OCT, or for that matter, even IVUS adjunct to imaging, the essence of what you acquire has to be used to improve the way we analyze our angiograms and carry out with perfect results for our patients. Thank you.
Dr. Reddy, excellent case actually, and nice demonstration on the OCT imaging. I would just like to ask you one question. You saw that distal dissection. Just let us discuss about the distal dissection of the stent edge, and how many cases will require stenting of that distal dissection. What are the parameters to go by? In your case, probably it was a biggish arc, the depth and the length of the dissection.
Yeah, the distal dissection many a time, OCT detected dissections, if they are very small ones, less than 2 mm, confined to a very small area, and if they are in the retrograde direction, I don't think you need to attend to it. But if you find something which is having a bigger arc and more than 2 mm, of course, like in this case, it makes sense. And in this scenario, in fact, we would sure that the chances of a distal edge dissection are quite high because the basic pathology was a SCAD prone scenario. So you are very right. Many a time we might not be needing a distal edge.
I welcome Dr. Devdatta Bhattacharya as an expert panel member. Sir, you can add some few comments if you want.
Dr. Devdatta, you're on mute.
Unmute. Dr. Bhattacharya, unmute.
Yeah. Thank you. Yeah, nothing more to add. This is an excellent demonstration of a well-recognized condition, and the surprise was that distal edge dissection. Probably the 4 mm stent that had caused that distal edge, because the vessel was tapering down a little bit. It was much bigger at the site where the thrombotic, that lotus root appearance was. And that can happen. So the OCT detected it and it was stented. So that's fine.
Fantastic case, Dr. Reddy. I think you gave a really good overview on, recanalized thrombus, and took us through history. It was just a great talk all around. And again, thank you so much for that. I think in the interest of time, and I would love to now invite Dr. Kane to give the talk on triple bifurcation complex PCI.
Yeah, good evening. Can you see my slides?
No.
Not yet, sir.
Not yet. I think I gotta start screen sharing.
No, I have started screen sharing. Okay, some issues of force quit. I don't know why it's happening. I was all set with this. Just 1 second if I can do that. Can you see it now?
No, Dr. Swami, we are not able to see your
Okay.
screen.
Can the next person go ahead? I think I'll just work out what's happening. I don't know why it's happening like this.
Sir, can you test right now, sir?
It's not seen as that now. Not seen.
No, sir. Dr. Kane, sir, would you like to test once again?
Yeah, I would.
Yeah, just try once, and if not, it'll
Yeah,
move
okay,
on.
now I'm there, I think. Let's see here. Yeah. Okay.
Yeah, that's
You're there. Got it.
Yeah. There's some problem with my laptop. I don't know why. Let's move. Just 1 second, it's coming. No. Okay. Yeah. Thanks for the invitation. I wanted to present a case where I have to ask some questions, actually, and difficulties which I faced. This is a patient. Oh my God. So my computer is getting hung. I don't know why.
Sir, can you click on the escape and
Yeah, I'm trying to. Yeah. Okay. Can you see it now?
yes, sir.
Yeah, but so I don't know if I go on the big screen, it's producing problem. No. Okay. So this was I'll go really fast now. 53-year-old female, NIDDM, non-insulin dependent diabetic. She had an inferior wall MI about a month back before this admission, where a PAMI was done, and that time there were bifurcation disease in LAD and circumflex, and there was a doubtful shown by the operator there that could be mild plaque at the left main ostium. She refused surgery, obviously, because of multiple bifurcations. She was asked to undergo surgery, but she said she doesn't want to undergo surgery. I'll just show you these lesions. Now, this is LAD diagonal bifurcation, classical. Then this is circumflex bifurcation. And let me tell you, when we did this, we thought, at least initially, I thought that probably this area would be not very significant, and I would get away with a bifurcation here, and my plan was to do an ostial left main stenting, because we realized the moment we engage the guide, the pressure is to become zero, means it is to drop, and we had to take out the guiding. So that is the first time when we took, and we had prepared for an OCT. I didn't ask for an IVUS. This is done in a public hospital where you have to struggle to get the imaging. Very rarely we can get, because this patient, the angioplasty was free, but she had to pay for the imaging because that is not allowed under the scheme. So we planned for this. So I first did the circumflex, dilated the left circumflex, and then the OM, and then stented the OM. And after I stented the OM, this was the result. So then after that, I did the OCT. And the OCT showed, if I can, now my main problem was this: I could never get good pictures of the OCT because of the left main ostial disease. Despite struggling so much, it was quite difficult, but we could manage to get most of the information. So the information that mainly I got was that there was no calcium anywhere, so I was happy. The sizes I got, but I could not get very good pictures. So in this OCT, you can see that there is a dissection proximal to the stent, and the pictures are not that good. And the LCX ostium was around 3.8 millimeters square. So, and this was the picture after the stenting of the OM with a provisional technique for the main circumflex, distal circumflex. So we knew that now we are ending up with something which is coming close to the left main bifurcation. So we may end up needing a left main bifurcation treatment also. So I kept this wire here only, and I wanted to go to the left side so that we can finish up with the distal LAD. So we put 2 wires, and this was the disease. So we dilated both the lesions, did an IVUS here, did an OCT here, and okay, and then this was the OCT. Here again, the same thing, because of the left main ostial disease, the picture quality was very, very poor, and a lot of blood was coming in the this thing. But however, we could make out that there is a distal dissection in the LAD, in the tapering LAD. It was a long disease with a dissection starting very distally, and then the main disease coming up here. But this we were aware of it. Only thing is, again, there was no much calcium, so I was happy with the fibrotic and some little bit of lipid. But the ostial LAD was diseased. That's what we realized. But the left main was roomy and good and almost 4.25. With obviously we could not get the left main ostium. So the information was good enough for me to roughly judge the sizes of the balloons, the need of modification, whether it's required or not. There was no need of any modifications. So I went with just NC balloon and the stand. And so I went with the crush technique here because there were multiple bifurcations and I wanted to do a relatively rapid job. So we did a diagonal stenting with a 2.5 by 24 balloon, and then crushed it with the LED balloon, and then stented the LED with a 3 by 2.75 by 48 millimeter stent, because it's a long disease that had to be covered. And what I realized because of the OCT, it helped me that the distal was around 2.75, mid was 3, then 3.5. So LED had 4 sizes as it reached the left main ostium. And because of the OCT, I could do graded dilatation subsequently as a post dilatation after stenting. So this is recrossing, kissing, final pot, and then this is the result after that. I'm going fast because there were so many bifurcations which I had to tackle. So this was the result here. Then we realized that we have to do left main bifurcation. I went, so this was the picture after this. You can see that the circumflex is showing more and more stenosis at the ostium. And there was a dissection in the just proximal to the distal stent in the OM. So we decided to dilate the left main and the proximal LAD and complete that. And I wanted to do a tap to the circumflex because it was almost at a 80 degrees sort of a angle. So this was a good view to see the left main ostium, aleocranial, which we generally always find the ostium in a very, to profile the stent. I generally use this view. So this was dilated, and then this was stented, a long stent, 4 millimeter stent I used by 24 stent to cover the left main and the LAD and overlapped with the previous stent, and dilated the overlapping segment with the 3.5 balloon and the proximal left main and the proximal LAD with the 4 and the left main ostium with the 4.5. That's what we had judged from our OCT pictures, whatever we could get. And this was the result in the left main and the LAD. Very satisfactory result, I would say. And then we went to this final, to the tap of the circ, and you can see that this was it. So I crossed distally with the distal cell to the best of my ability. I didn't use OCT after that, and then removed this wire and then dilated, pre-dilated it and went with the tap stent. And this is the stent that we did. And then obviously, again, you do a kissing and a proximal pot where you have to be very careful not to crush the tap part, the proximal part of the tap technique that you have used, because the stent comes inside the lumen. And this was sort of the final result which could get in this view. And this was a final. I always try to do a final left main ostial dilatation very carefully before I take any pictures, because many times there is longitudinal deformation which you have to try and avoid. So that's my final thing, and this is the final pictures that I have got. Now all the bifurcations, fairly good result, I would say. The OCT was not to the best of my, the best that I wanted to, but it could still give me a lot of help. These were the stents that were used depending on this. In LAD, I had to use 3 balloons, 2.75, 3, 3.5, and 4. So this information, you are very comfortable when you do an OCT that there's no calcium. You are exactly judging the size of the vessel. So you're not going to cause any dissection and unnecessary perforation or a proximal or a distal dissection. So that was a major help in this particular patient, and to know the size of the left main, obviously. So how the OCT helped me in this patient, I wanted to say that it reinforced my non-imaging judgment. Normally we do it in public hospital without, even in private, I do only 10% of my cases go with this. There was no calcification, so that helped me a lot. need for left main bifurcation stenting, I realized as soon as I did the first OCT of the circumflex, then I could use adequate size of the stent and post dilatations. And in the long tapering lesion of LED, I could decide on the exact size of the balloon at 4 different sites. And I could use proper technique, provisional crush tap, and get the best of the result to the best of my ability and my understanding. So the message that I wanted to give was that in such a complex patient with multiple bifurcations, you need meticulous planning. Good assistant with good coordination is very important, because I have realized that if your assistant, you don't have coordination, the wire crossing this, that, so many times the wire comes out and you have a problem. But here I had never had any problem, because our colleagues, we are almost always work together. So it's a very nice team. Change of plan may be necessary as the case progresses, choosing the right imaging technology. Now here, we were not very sure about the left main ostium. Otherwise, probably I would have used IVUS right from the beginning. But so, and every technology that one uses, we need to have a learning curve. We need to master the technology. So performing all the steps of bifurcation techniques you choose are very important. So I have a question to my learned panelists, that how do you do ostial left main disease OCT? Is guideliner helpful? Then after having done all injections by the Abbott person who was there, he said, sir, you should do hand injection. So I said, no, now I don't want to do hand injection, because we had already finished with a lot of dye, because multiple times we tried it. And the final question that I had, should I have done the left main? Now that I used OCT, should I have done the left main first and then gone for the rest, which I also don't think I should have done that, but it's just a query. But main query I had for my learned panelist is, how do you all do left main ostial OCT whenever you require, or you'll end up doing OCT and you don't have an IVUS? Thank you very much for your attention. So can I stop sharing and we can discuss maybe?
Yeah, so first of all, Dr. Kane, excellent case. Actually, you have done 3 procedures of bifurcation, the provisional stent in the OM, the mini crush in the LED diagonal, and finally a tap in the distal left main bifurcation, although your ostial left main was also diseased. We know that the OCT is not a very good imaging modality for the ostial disease. I mean, it's well known. Now, your second question of doing first left main or doing the other things, probably if you had done a left main earlier stenting, all your hardware would have passed through that particular stent. So probably what you did, the distal lesions tackling first in the circumflex and in the LED D1 was a right decision, I would say. The other panelists, if they have other different viewpoint, can please come in.
Again, great case. I think fantastic result given the resources that you had there, and I mean, looked really good angiographically. And I understand why you didn't do a final OCT run. Just to kind of answer the question that you said, I mean, obviously I agree with with what you have said and what has been said already in terms of for IVUS. I mean, for imaging the ostium, I mean, and clearly IVUS is that's the one area where IVUS kind of trumps over OCT. Now, however, that having been said, and if you've already opened an OCT catheter and you want to do it, I mean, there are certain workarounds. I mean, yes, you could use a guide extension catheter to just, and then disengage the guide and try and do it there, and you can see around it. I am told that telescope is supposed to do a better job. I haven't tried it with telescope yet for imaging it. But yeah, typically using a guide extrusion catheter, which does not have that, the marker, which is going to, you can still see beyond it. That's kind of the point. Now, there's also supposed to be a static mode. I tried to do that where you're not actually doing the whole run, but you can just image a point or like one particular area. On OCT, I've tried that. It's kind of with mixed results. But I would say if you had to do it with a guide extension catheter. Now, I would also love to have some of the other panelists comment on this case, and then perhaps we will then move on to Dr. Haresh Mehta to give the next talk. Dr. Gopi, you've been kind of quiet there, so do you want to just anything to add to the case at all?
No, it was a wonderful case, multiple bifurcations done parallelly, but I was just curious about what about the distal circ where we've done a provisional. Would you have done a physiological assessment of the distal circ after done a provisional there?
Yeah, I could have done a physiological and I could have stented that if required, but we thought it was an acceptable result, because there were too many things to be done. So you can always, obviously, it would have, it would have been the ideal thing to do, that you always, but there was no, see, normally in a provisional stenting, you stent the side branch only if there is a dissection, if there is an occlusion, or if the patient has angina, or if there are ST changes. None of these things were there. Patient was absolutely stable. So there was no indication to do that. And there was a peripheral branch, which I wanted to leave it alone because there was a good flow, TIMI3 flow. So there was no definite indication to do anything as such. I hope the other panelists agree with me on this.
Yeah, point is well taken. Thank you.
I think that's a great point. Yeah. So
Yeah,
let's
thank you very much. Thank you very much.
Invite Dr. Mehta to give the next talk.
Yeah, hi.
Hi.
So thank you, Dr. Kasturi, to hire me over, and I'll try to be very brief because there are not too many cases of strut fracture that I've seen, but I'll try my best to do what I can. Can you see my screen? You all see my screen?
Yeah, we do.
Can you hear me?
Yeah,
okay.
now.
Yeah, we see a screen and now we're seeing your presentation.
Okay. So these are the different types of fractures that have been described: partial, complete, and there is mild, moderate, severe, and there's gradations from 1 to 5. Different people grade it differently. And these are the multiple gradations and how they are. Someone calls it avulsion, someone calls it complete fracture. We won't go into that. And the commonest locations are right coronary artery, followed by LAD, and the subvenous and circumflex. Left main is the lowest of the lot. Fractured right coronary artery seen by MDCT. You can see a clear separation here between the two pieces. I'm going to put a small case and then I'm going to have a couple of discussion points with you all. This is a 77-year-old female, previous angioplasty of ostial RCA done in 2015. In 2018, ISR was treated with another DES and recurrent angina. So this was the picture in 2016. It was post PCI, and again 2018, again post PCI 2018. And the OCT image in 2018, and if you see here, the suggestion of a calcified nodule, which probably could have caused this problem, vulnar expansion or a strut fracture. Probably you don't see stent struts around here, not very clear. But if you see this angiogram, this point is the place where probably the strut fracture happened. This is how it looked. The MLA went down to 2.07. There are some areas missing here of the stent, some area missing here, and these were the two probably calcified nodules, and where this led to this problem. And then there was an NCN cutting balloon dilatation followed by shockwave IVL. Unfortunately, we don't have a laser, which would have been ideal in such cases to get an adequate expansion of your stent, but we don't have it here. Maybe a directional atherectomy. This was the end result with a reasonable MLA. And this is the OCT picture of a strut fracture. This is how it looks in the longitudinal view. This is where the strut fracture is. And then you see absence of struts in that area. That tells you that that's the area of strut fracture. Another way of looking at it is borrowed from the article on strut fracture. If you see here, these points where there's a focal reach stenosis, generally strut fracture does come with focal reach stenosis. Now, the important thing I want to discuss is that many a times there are multiple factors that lead to strut fractures, and they are either technical factors, or they are stent factors, or they are vessel characteristics. One of the main reasons is a persistent calcified nodule where you try to expand and you try to overdilate the stent and lead to strut fractures. An angulated vessel, or it is seen more in saphenous vein grafts. It is seen more with sirolimus eluting stents because of the closed cell design. It is seen with more bifurcation and crush where you use multiple balloons to expand the stent. And of course, whether these strut fractures lead to any outcomes or any bad outcomes, of course, the rate of strut fractures varies from 1 to 10%, and the outcomes vary from TLR, ISR, and it can vary anywhere from 10 to 50%. And the commonest presentation is stent thrombosis, leading to ST elevation MI or a non-ST elevation MI. And in many of them, you don't get anything. and it is more when you have complete fractures. The unanswered questions which I would want to discuss so that I'll finish my presentation early is what is the modality of treatment for symptomatic and asymptomatic strut fractures? What would you normally do, because there is no consensus? Second, whether just leaving it with a drug-eluting balloon or just do a laser and do a balloon, or changing the stent, like a CS to be stented with a Zotralimus, or trying to use the same drug or not using a drug-eluting stent at all. And of course, look at the preventable causes. So you have a controlled post-dilatation, as Dr. Kane said. Is it better to image all complex lesions at the first insert itself to reduce or prevent strut fractures? So I'm going to leave you all now with this talk and we can discuss it further. Thank you.
Fantastic talk. Thank you so much for sharing that. Dr. Jabir, like, do you want to add on something to this? If not, we can kind of just open it up to the panel.
Jabir sir, we can't hear you.
Dr. Jabir?
He's muted, sir.
Oh, okay. I mean, Dr. Sushil, do you want to, any comments at all about, about the case? Yeah.
What we were discussing is, repeated stent failure, basically because of the unsuitable anatomy at the first go. So if you would have done imaging right at the first go, probably, the absolute well-apposed stent and fully expanded stent would have prevented this kind of complication in the long run. And she has had, I think, 3 or 4 times PCI only because of that problem. So now, in retrospect, it is very easy to say, okay, we could have imaged and done the thing properly. But once it is there, now you have to treat that. And what is the best modality of treatment after that? Despite that, can we manage that calcified nodule now, despite the 2 previous stents? And probably people have done the either a IVL or a rota plus IVL kind of combination. You have to fracture that nodule, and now what you are putting, the next stent has to totally expand in that lumen of the vessel. That's what I feel.
I think that's a great point. And I think, I mean, in general, just to kind of put it out there, and I think we've already kind of discussed this, there is no general consensus in terms of how do you treat stent fracture. It's a complex complication, obviously, to treat. I guess it depends on, the type, the presentation, the symptoms, presence of factors that will predict recurrence, right? I mean, is it a calcified lesion doing this? Is it tortuosity or extreme movement? Is it technically a super complex angioplasty? So, I mean, I guess the treatment really options, I mean, you obviously don't want to, if you can mitigate some of these factors that predispose it to happening again, you got to do it. So, I mean, either do you want to just balloon it after that? Do you want to restent it? Or some cases, I mean, have we done enough damage and should we consider CABG at this point? I mean, again, these are all, it depends on what is causing this.
The stenting of the stent fracture should always avoided. Hello, Arun.
Hello. Yeah. Hi.
Yeah, able to hear.
Vijay sir, we can hear you.
Yeah, please go ahead. Yeah.
The stenting of the stent fracture always should be avoided.
No, I don't agree, Arun.
That's an interesting.
It's other way around.
That's an interesting statement. Yeah.
Arun, let me comment.
Easier said than done, actually, in retrospect. Yeah.
No, recent the SKY consensus document says if you have a ISR because the stent fracture, one of the recommended or in between stents, if there is a gap, the stenting is must. So that stent fracture restenting is recommended by the recent consensus document by the SKY. And at the same time, the right coronary, the stent fracture is one of the commonest side because one is a torsion, another one is a longitudinal compression. The mid RCA, the excess motion compared to LAD and LCX, even in the absence of calcium, the right coronary, particularly mid segment, prone for fractures. So the fractures, if you see the maximum incidence among the 3 vessels, right coronary mid, because the one is longitudinal motion, one is torsional movement. So because of that, it gets. And even if you see the calcium nodule incidence, much more in RCA compared to other. Why? Because this motion contributes to break in the calcium that lead to calcium nodule. So even if you see the calcium, first maximum incidence is the right coronary followed by the LAD. And because the stent, untreated stent fracture invariably lead to ACS or ISR. So stent fracture, because it projects inside, definitely it lead to more irritation, myointimal proliferation.
Yeah, and I think again, great points, Dr. Sridhar. Thank you for joining in. And again, you know, it is one of those things where it's a general rule. When you say it never is an answer, that's usually typically unacceptable. So it really depends on what, like I said, what has predisposed the whole thing to. Why did the stent fracture in the first place, right? Where is it? How is it? Why? I mean, what is the concomitant stuff? Do you have ISR on top of it? Is it an isolated one? How bad is it? I mean, I think you got to put everything in perspective before you decide what you want to do with it. And again, I think that's a really interesting thing. The other place, Dr. Sridhar, where I would say in one of those preventable things is when you have a graft touchdown on, say, and many times we have seen this in a circ, it often leads to extreme tenting of the vessel. And if you're going to fix the native at that point, just remember, as Dr. Sridhar so nicely put, all the forces that are going to act and the constant movement that this stent is going to be subject to across during every beat for the rest of that patient's life. So I think, you know, prevention is key, but then if it has happened, figure out why it happened and how you want to manage it.
Yeah, Arun, that is one of the reasons that you don't stent the muscle bridge. I mean, that's
Absolutely.
one of the causes of stent fracture.
Yep.
Yeah.
Great points, guys. I guess we actually have extra time. I just kind of was notified that unfortunately Dr. Lakshmikant has not been able to join us due to some other unforeseen circumstances. So we have Dr. Shivkumar to give the next talk, and then we can discuss about all the cases if we have more time.
Yeah, sure, Arun. Let me share my screen first. Hope my screen is seen.
Sir, your audio is great.
Dr. Shivkumar, your audio isn't clear.
Dr. Shivkumar, sir, I think you have a poor network. Can you switch off the video?
No problem.
Shivkumar, sir, we can't hear you.
Can you try turning off your video?
See my friends.
Dr. Siv, are you able to hear us?
Arun, YVC.
I think poor connectivity. Ravi is speaking on phone.
Yeah.
So meanwhile, do you want to go ahead with the next talk? Dr. Sridhar, sir?
Yeah.
Meanwhile, should we go ahead with the next talk?
Yeah, just to speak to him once, then we'll move on to the
Okay, we'll wait for a minute, sir.
Wait for a minute, then we'll move on to the next topic. I think he has a poor connectivity.
Hi, Kirti. Shall we, is someone like reaching out to Dr. Shivkumar, or shall I call him?
So we are unable to get his phone as well.
I think poor connectivity with the phone also, not only this.
Then we'll move on to the next session.
Yeah, we have Dr. Kirti already.
Yeah, we will move on to the next session, that is keynote lectures. The expert panel, Dr. Neil Johnson, Dr. P.C. Rath, and myself, and moderator, Dr. V.T. Shah. And first topic, I think Dr. Kirti Punamia is there.
If
The
it's
first
possible
topic is role of imaging in ISR.
If it's possible to ask, I was wondering if perhaps I have some clinical duties later in the hospital. Would you mind if I give my talk first, perhaps?
Okay, sir, you can proceed. I will request Punamia to talk later.
Oh, sure, or
Dr.
second,
Punamia,
that's
are you
fine. First or second, if you'd like Dr. Tumania to go first, that's fine. I'll go after that then.
Dr. Kirti Punami, are you able to hear?
I can, yeah. I'm able to hear you.
Dr. Neil Johnson wants to talk first. Is it okay with you?
Or if you'd like to go first, I'll go second. That's fine. I just didn't want to be at the end of the session, if that's possible.
You can
Okay,
go
great.
ahead.
So, can I quickly just go through my talk? I'm ready. I mean, if you are
absolutely
ready.
Go for it. Yes, please. Sorry
Okay, sounds good. Great. Thanks. Okay, let me just share my screen. Yeah. You're gonna just have to give me 1 second, and I'm gonna get this going. Okay. I am having some trouble over here.
Then let him talk. After that, you.
Why don't you go ahead and I'll just get my permissions to share screen with the new OS. Yeah.
Understood. Well,
Johnson, you can go ahead.
Please go ahead. Please go ahead.
Let's hope mine has better luck. You know how it is. It's sometimes an issue with everybody. Is mine available here? Does this look good?
Yeah.
We have your slides, Dr. Neil.
Okay. And this is then about a 10-minute or so talk, as I understand, with a bit of discussion afterwards. Perfect. So thank you so much, everyone. It's been a pleasure to participate, and I've really enjoyed all of the cases and presentations so far. I've been asked to talk about this kind of long-standing debate over the past 5 or 10 years or so, looking at resting indexes versus FFR for physiologic decision-making for revascularizations. No important disclosures. And I think it's important to begin by understanding that actually resting physiology was kind of where it started. If you go back to the work of Andreas Grünzig, you can see that he was making resting gradient measurements at the very beginning of angioplasty, and that even as we've started to talk about post-PCI FFR measurements, even back then, the gradient after PCI and before PCI was taken as a measure of the success. And in fact, in some of the very early cases at Emory, where Dr. Grünzig then immigrated after leaving Switzerland, they would go in and make resting measurements in order to understand whether or not to do angioplasty. So even using resting physiology as a diagnostic tool. Just as we've seen in the kind of modern era that post-PCI FFR measurements are important for outcomes, even after the very early angioplasty procedures, it was well understood that the residual pressure gradient was a measure of sustained success, as opposed to late failures that were seen with higher residual gradients. And we've, of course, talked a lot about how FFR matches up with stress testing results being abnormal. That work really mirrors even earlier studies comparing the pressure gradient at rest to then abnormal findings both on SPECT and treadmill, and finding that the lower the resting the gradient was, the more likely it was that patients had either an abnormal SPECT or treadmill or both. And it was maybe 20 years ago or so. Now you can see this was a paper from 2000, so now just over 20 years, that really began to focus attention on subcycle measurements during the cardiac cycle, in this case diastole, because of course a lot of coronary perfusion happens in diastole, really a dominant component of coronary flow. And that then cycled back the development now several years ago of resting measurements during diastole, or subcycle measurements like that of the instantaneous wave-free ratio. It's important to understand that the initial hypothesis behind that the wave-free period had a resistance that was somehow equivalent to hyperemia that was seen in some of the early studies of IFR was later then not shown by that same group as they did wider studies. And as you can see here, there's really a natural hierarchy that they found when you're thinking about myocardial resistance. That is, resting whole cycle has the highest resistance, wave-free period or diastolic periods have a lower resistance. Hyperemic whole cycle measurements like FFR have an even lower resistance though, and you can see that here in the case example at the left where this patient had a much lower resistance during the FFR period versus the resting wave-free period. People began to notice then there was a relationship empirically, if you will, between resting measurements and FFR measurements. You can see these two scatter plots looking at FFR versus either IFR or PDPA. And it's intriguing that they all really show very similar statistics in terms of area under the curve or the correlation statistics or accuracy, all around 80%. That is 4 out of 5 times the two measurements agree with each other with about an 80% accuracy. And over the last 5 or 10 years now, we've had the development of a whole family of these metrics, what has now been called non-hyperemic pressure ratios, that really can be classified into whole cycle metrics like PDPA, something that's universally available, has been forever on all devices. Largely the threshold there has been 0.92. And then subcycle measurements. And these have largely been developed by each different company. You can see IFR from Volcano Philips, DPR from Opsens, RFR from Abbott, DFR from Boston Scientific. And they all give really clinically and numerically equivalent values. The positive threshold here is 0.89. And it's not just that the numbers are the same, but also the prognostic performance is the same. This is some large multi-center data from Korea looking at the prognostic value of adding on different resting metrics to clinical factors. And you can see that there was no between group differences for all of the metrics, suggesting similar clinical performances. And that really matches some other data coming from Asia, from Korea, China, and Japan, looking at the 3-vessel FFR Friends Registry, showing that the estimated 2-year vessel composite-oriented outcomes were the same across the various resting physiologic indexes of IFR, DPR, and RFR. And this has led the American guidelines anyway to really talk not just about IFR, which they say has been removed from the list, but really talk about this much larger family of non-hyperemic pressure ratios. So that's a bit of a history going all the way back to the very early days on resting measurements. What I want to do though is highlight this tension then between resting measurements and stress measurements and think about why we do stress testing in cardiology. This is the case of a 59-year-old man who has an intermediate LAD lesion that you can see there on the angiogram. And of course, at rest, everything is okay. He's sitting there in front of you in the office. He does not have any symptoms. You do an EKG that's normal. If you sent him for a resting perfusion study, he has no perfusion defect. And if you put a pressure wire down the blood vessel, there's no resting gradient in the LAD. So at rest, everything can look fine. But of course, the reason he came to you is not that he has symptoms when he's sitting there. It's that when he exerts himself, he has angina. On the treadmill, then, he has significant ST depression. And the stress test, although normal at rest, develops an apical perfusion defect in the LAD. And that IFR value of 0.97 can drop all the way down to an FFR of 0.73 with stress. And PCI, instead of medical therapy, really helped this patient.
Rosa, just answer the phone.
You can see here that the IFR value and FFR values, the FFR value almost normalized completely after PCI, going up to a value of 1. A repeat treadmill study showed that the EKG had normalized, and a repeat SPECT showed that the perfusion defect had also gone away, and the patient's angina went away as well. Now you might say, well, okay, that's a fascinating example, really shows the difference between rest and stress. But if this is such an important effect, why wasn't it seen in the randomized trials? You see here the conclusions from 2 different studies that were published back-to-back in the journal several years ago, saying that IFR was not inferior to FFR-guided revascularization. Well, how could that be if there were cases like the one that I just showed you? And I want to spend a bit of time explaining that. The first real problem with the way these studies were done is that 80% of the time or so, IFR and FFR agree with one another. That's been something that's been well seen across many different studies, as I've summarized here on this particular graph. And what that means is when a patient gets enrolled into a trial like that and is put into one of these two strategies, IFR, FFR, what it means is that 80% of the time, it didn't matter which strategy was randomized because the treatment would have been the same regardless of that because of agreement. In other words, agreements don't allow you to differentiate who's right and who's wrong, right? If you're driving down the road and Google Maps says to turn left and your other GPS software says turn to the left, well, you're going to turn to the left. They don't disagree with one another. And so cases like the one here where the two indexes match up with each other aren't helpful in understanding which one is more beneficial clinically. Instead, it's the 20% of the population, the 1 out of 5 cases where Google Maps says go left, and maybe your driver who's sitting next to you says, no, we need to go to the right. Google Maps is wrong. Those are the kind of cases then that we need to focus on. Interestingly enough, those are the kind of cases that happen more often in the left main or proximal LAD compared to other parts of the vessel. And also those are the cases that more often have a heart rate dependency. You can see that the difference between IFR and FFR is related to heart rate quartiles. And these two effects have to do with myocardial mass as well as the difference in diastole as it varies by heart rate. The second issue is that these trials, although they call themselves physiologic trials, really ended up treating a large number of lesions simply based on the angiogram alone. These were studies, kind of all-comer studies, if you will, and allowed operators to treat vessels simply based on angiographic appearance or based on non-invasive data. And as a result, if you go carefully through the tables for them, you'll see that just over half of lesions actually underwent revascularization based on FFR assessment. And the reason why, and I'm giving you the text here on the left-hand side, is that angiographically significant stenoses didn't require physiologic evaluation. Whereas in other trials like FAME, for example, every single lesion was slated to have an FFR assessment before PCI in the physiology branch of the arm, regardless of how severe the angiographic lesions were. And that's why if you go in detail through the FAME table, you'll see that 90% of the lesions underwent PCI based on FFR assessment. Of course, it's never perfect. Sometimes you have a CTO or the pressure wire fails or something like that, but contrast those two, I'd like to summarize in this table where you can see that FAME and FLAIR were really two very different styles of trials. FAME enrolled a very high-risk population by nature of studying multi-vessel disease. The average FFRs in FAME were much lower because they were including more severe lesions. Of course, there was more multi-vessel disease, but just the use of physiology was much higher, and it was the type of population that I really would consider high risk, whereas FLAIR enrolled a low-risk trial and diluted out the benefits of physiology through the kind of mechanisms I'm summarizing here. And it's for that reason that the American appropriate use criteria really continue to favor FFR. You can see they say there's language there that the non-hyperemic pressure ratios are not as well validated, have not been studied as well, and they really want to say primarily focusing on FFR because of its well validation. But I think, and this is my final slide, the conclusion, the takeaway message that I continue to emphasize is when we think about why patients have symptoms and when they have symptoms, it's during stress conditions, it's while they're exercising, it's while they're being active. And when we perform a resting assessment in the cath lab or when they're sitting there in front of us in clinic and they say, hey, I feel fine right now, I just want us to understand that because those are two different scenarios, it leads to a little bit of internal contradiction. To make a resting measurement, let us understand what's going on with the stress physiology that might be producing the symptoms that bring the patients to see us. Thank you so much.
Thank you very much, Dr. Hill Johnson, for excellent lecture. And I'm also very, very thankful for joining IPS as a course director and as a faculty member. Really, we are very much honored to have you here, and your contribution invaluable to us. And you highlighted many important aspects. Thank you very much from the bottom of the heart.
Thank you so much. Maybe some time for brief discussion. Yes, Dr. V.T. Shah.
You can,
sorry, just one question. So after your talk, what should I assume? Should I do first NHPR, see if it is abnormal, then there is no need for FFR? Or you would say that just don't do anything, just go ahead and do an FFR, forget about NHPR?
It's a great practical question, and I'll be honest that I don't always use adenosine. I almost always use adenosine, but not always. If you put down the pressure wire and there's just a huge gradient and you can move the wire around and say, oh, listen, all of the gradients right here in the vessel, clearly you've understood what needs to be done in that vessel and you've reached a diagnosis. And I'm practical like that too in the cath lab. And so I don't want to be someone who's dogmatic that it always has to be one way or the other. What I would bring up though is when it'd be like a patient walking to the emergency room and the leg's broken and the bone's sticking out. Like you don't really need an x-ray, you know that the leg is broken. But when resting measurements are normal, I continue to wonder, why is this patient having symptoms? Why are things not going well for the patient? And I think the added value of making stress measurements has taught me a lot and allowed me to uncover pathology that I would have missed by using resting measurements alone. And as a practical consequence, when gradients are bigger than stress, it's much more easy to find where they are in the vessel to help figure out these are the spots that I need to stent. These are the important places in the vessel to treat. What is diffuse disease that can just be managed medically?
Yeah, and during pullback for diffuse disease, what do you think? Again, FFR would be more reliable than NHPR, or?
You know, for me, one of the key issues is signal to noise ratios, right? So if you've got an FFR of 0.7, that's usually a gradient of about 30 millimeters of mercury or something like that if the aortic pressure is 100. Understanding where you have drops, if you have a 30 millimeter pressure head to start with, that's something that you can do. An IFR becomes positive somewhere around 10 millimeters of mercury or so. Imagine trying to find out where the gradient is when you just have 10 millimeters of mercury to work with. Small fluctuations and a little bit of pullback drift can really affect measurements. And so I think for a lot of practical reasons, big things are easier to measure than small things. And that's another practical benefit of hyperemia. The gradients are larger.
Yeah.
Do you feel FFR is recommended? Suppose if the female patient falls positive treadmill, maybe we are not sure, but angiogram wise, 70 to 90% lesion, but clinical symptoms are not suggestive. So do you suggest FFR mandatory for these patients? Because even recent recommendations, they are saying even 70 to 90% lesions, the negative rate is almost 20% FFR. So that's the reason if angio, though the treadmill may be positive, but it may be false positive. In such cases, if symptoms are not significant, is it must to rule out by FFR interrogation?
You know, I must say, I do a lot of FFRs for fairly significant lesions. I took a look at my last 100 FFR cases, and my average FFR is 0.76. 0.76. That means, and the lowest one I had in the last year was 0.32. And so, or the last 100 cases. So those are, I tend to want to really be sure before I commit someone to PCI that I think that we're going to make a difference for things. And you might say, well, that's a little bit of an extreme view. I live in a place where I'm able to have total access to pressure wires and no one gets on my case about using them too often. And so I'm sensitive to that issue. But I would say that your 90% and my 90% and other panels' 90% can often all be quite different. I think that's a well-established variation in how people interpret angiograms. And so a treadmill for me is not a specific enough test to figure out if a particular lesion is causing a problem. If it's subtotal or a total occlusion, I think we all agree on those ones, but there's a very wide gray area in the middle there. And I tend to be someone who really pushes that gray area with measurements in order to be able to say to patients, hey, I really think this is going to make you feel better and be the right thing to do.
So what about an FFR value of between 0.75 and 0.8? How would you interpret vessel-wise or some other test or correlation with symptoms?
In that area, I put all of the factors that you say together: severity of patient symptoms, how focal is the pressure gradient, is it a technically straightforward lesion, a complex bifurcation, is it ostial, is the patient able to take antiplatelet therapy, what's coming down the road for the patient. For example, earlier colleague's case about the kind of person who has pancreatitis and other procedures coming up where you really want to be cautious about things. I try to put all the clinical data together, try to be a doctor, try to put put the whole picture in view and use the FFR value and the pullback as a strong piece of data, but by no means the only piece of data in that to make the best decision. So it's not always the same answer. I've treated FFRs of 7.7 both ways.
Recent recommendations like a mere presence of FFR positive is not enough, and that myocardial supply should be more than 10%. If more than the myocardial territory more than 10%, then FFR positive, then only you do it. How do you comment about this?
Yeah, it's a great point. And we've all had that experience when we're wiring a vessel, say an LED, and the pressure wire goes into a small little septal branch or something like that, right? And all of a sudden the pressure just damps completely and, you know, the pressure gradient. So you can see when you go into these little side branches, you can get large gradients that are not meaningful. We're not going to go around and stenting those little small septals. Now, I use that case just to point out the fact that you bring up that the amount of benefit that we have for patients depends on how much muscle is supplied by it. And actually, if we're a little bit honest, we have some crude ways of doing that in the cath lab, right? We're all very focused on the left main. We're all very focused on the proximal LED and getting those right. But we don't have tools that easily allow us to say in the cath lab, that diagonal branch supply is 5%, I can leave it alone. That other diagonal branch, that's 15%, I'm gonna go after it. You know, we struggle with this with bifurcations quite a bit, right? When should we go for that 2-stent strategy versus provisional? And a lot of that also hangs around with how much mass is supplied by those. One of the things that I think is useful here is that non-invasive data can help, you know, the size of the perfusion defect, that's also one quantitative thing. But in the cath lab, the tool of reference vessel diameters is useful. And also the FFR itself depends on the amount of mass. The same stenosis for a larger amount of mass is going to have a lower value, which is why FFRs tend to be lower in the proximal LED in the left main, as I showed on that slide too. So I guess to put it together, I try to stay away from small vessels and I try to stay away from small branches because those end up making the PCI more technically complicated. Even if the FFR is positive, I'll leave a small OM side branch alone and just accept it as is for medical therapy. That's not going to cause angina that's unable to be treated medically.
Okay, Vitisha, can we move on to next?
Yeah, sir. So let us
thank
go
you
ahead
so much. I'm gonna.
Yeah, thank
I
you
have to
very
go
much,
around in the
Neil,
hospital.
for that.
I really appreciate the
And,
invitation, Dr. Kasturi, Vitisha. Thank you so much.
Secondly, for standing all throughout these 3-4 hours you have been with us. Thank you very much, especially on a working day. Yeah. So, Kirti, everything fine now?
So far, so good. Yeah.
Yeah,
Just
good.
a little security issue.
You can go ahead.
Yeah, please. So, let's see if you can share and.
Okay. Are you able to see my slides now?
Yes.
Can you see my slides?
Yeah, it's coming. Yeah, great.
Yeah. Able to
Can you hear me as well?
Yeah.
Great. So yeah, it's a fag end of the day. It's getting late, so I'm going to be brief and to the point. I've been asked to talk on imaging and ISR, and I think I want to start with a story, like I usually do. And in 2009, this 39-year-old gentleman presented with ACS, and you can see, realize that he had a right coronary artery, which is probably responsible for these ACS. The LED looks like it has some plaque. It's a mid-segment beyond the diagonal branch. Most of us in the current times would have put in an FFR wire or something and looked at it. And after that talk, might have had have to have a strong reason to chase it. But we did things differently in those days. And my colleague who did this case many years ago at that time went and fixed this RCA, which was good, and then went and put in a stent in that LED, and that was the final result. So what happens to this 39-year-old as he goes along? In 2014, he develops an ACS again. And when he develops an ACS again, this time he has a lesion. If you remember correctly, he had a block which was just about beyond that diagonal branch. And now that block has gone and come onto the proximal edge of that lesion into the involving the bifurcation. So he has another angioplasty done at that time, this time a bifurcation stenting with a mini crush. And that's the result to the left. And the edge of the stent is left 5 millimeters into the ostium of the LAD, thinking that they shouldn't encroach the LAD. You can see that he's got a moderate lesion in the circumflex, which was not treated at that time, and rightfully so as well. Now, the story doesn't end for this 39-year-old. In 2019, he presented with ACS this time. And before he came to me, he underwent a CT scan. So this is a CT. And this CT, when I analyzed it, it looks like you can see layers and large overlaps of stents which are present. You can see that the bifurcation stenting is seen there. But what you're seeing is that dark area which is marked by the arrow in both those areas. And that signifies that there is an edge plaque which is not letting any filling of contrast. And that's where we expect the lesion to be. And it's very close to the ostium, and one can actually physically understand the edge area and what landing zones he might have. Of course, this was the angiography that we found. Now, once we've had this, you don't need much really. You need to have enough to go in. And the questions that one needs to ask is, why did this happen to this young man? The second is, how could imaging, maybe in 2014 or in the last angioplasty, have helped and made a difference? And the question is, what do we do now? So I guess these are the questions. That is what actually sets the stage for telling us that we probably need to do things differently in the current day and age. Now, this gentleman, his LAD, after it was dilated, you can see that there is the upper layer, the upper row of images starting from the left show the landing zone in the stented segment just before the bifurcation, just proximal to the bifurcation. And you can see that the luminal diameter over there of the stent is a little under 3 millimeters. As you come proximally, you can see that the second image from the left on the top shows that the diameter, it's not a circular image on that stent. And the luminal MSA, a long term from previous stent, is around 6.6. This is when a 3.0 stent has been placed and a pot has been done, perhaps. But in a plaque burden, in a reference vessel, which is 13.5. Now you see that the 13.5 is a little more than the ostium of the LAD, which is 12.5. And this is very classical of in-stent restenosis, and this indicates the positive vascular remodeling. And this also indicates the toxicity of the previous generation stents that we're talking about. And so you will often see that the external elastic lamina is slightly enlarged in those areas. And so that cannot be a final destination. But there was some element of a deformation that might have happened at that from the guiding catheter or a partially non-expanded stent in that area, which might have been, and if you come proximal to that, the plaque burden is around 65%, which is probably the reason why the edge of the stent probably was left in an active area with a large plaque burden. To the left of the image, you can see a left main, which is pretty good, and it has a 4 millimeter diameter. So is a large accommodating thing with no major stenosis at all. The most important image that I look at this is the one which is in the bottom, is the circumflex ostium with an area of 7.2 millimeters square. I think it tells me that the circumflex ostium doesn't need to be touched. And I really, in my practice, I don't look at those arteries. I don't even put in a wire to protect them. This imaging taught me that the edge plaque burden is more than 60% of the previous stent. The proximal edge stent MSA is 6.62 millimeters. The ostium of the LAD is more than 60% plaque burden, and the left main has a landing zone of 4.1. So it tells me that whatever I do, it's going to be a stent from just before the bifurcation in the LAD, extending into the left main, enough so that I can do a safe pot in the left main, and I don't have to touch the circumflex ostium. We have clarity on how this might have happened and how to correct it now. So we did exactly that. And after completing the procedure, you can see that now the landing zone, the edge over there is 8.9. The ostium of the LAD, you can see the circumflex down there is the MSA is around 10.3, and the left main is around 4.3 millimeters in diameter, which is an extremely well expanded stent with no malapposition at all. Hopefully this time around, we've done the right thing for him, and this will be durable for him as well. And time will tell us. Now, the question is, how do I know that we might have done something wrong in the last case? Is some of our present cases. This is a gentleman who had his angioplasty done elsewhere a few months ago, and this was for an unstable angina. You can see that along the two arrows in the LAD indicate the target lesion, and what the artery in question being the LAD at this time. And what the operator did was put in a large, long stent distally. Secondly, put in a second stent proximally, sparing the ostium of the LAD, trying to land it away from the ostium, which is what most people I see doing sometimes. And then this is the result he got, which looked great. And actually, an OCT was only done post-stenting. And the proximal edge stent was around 7 to 8 millimeters beyond the ostium of the LAD based on the OCT. Now, the OCT run was there. And what happened was, this is the OCT run here. We can see that it's a complete run and we can watch on it. But this is what the OCT, which I looked at later, showed me. If you look at the transaction from this entire longitudinal segment, and if you look at what should have been the anticipated or expected MSAs are on top, which is 6.5, 7.1, 7.4, 7.5, 8.5, and as you come proximally, such and such. But actual MSAs were 4.6, 6.2, and this was a gradually very, very ill-expanded stent all through. And what was more interesting was the ostium of the LAD, which was around 3 millimeters of the edge of this stent. This was the plaque burden. You can see an extensively high plaque burden and a very lipid necrotic plaque. In the current context, if we are going to do an OCT-guided angioplasty, then it would be absolutely not right to have left this edge at the end without a cover of a stent. Naturally, this patient came back at 4 months, and that was exactly where you can see there's a recurrence. So doing imaging is not enough, but actually analyzing that image to make sure that your angioplasty, every step of it is guided by it and not just the MSAs and the apposition. I think that is of prime importance. And sometimes I think we may be faltering in achieving all those issues correctly. So what do I do? This is a case I shared from, I did it along with Harish Mehta, a colleague of mine, and at his request, a 75-year-old lady who had unstable angina, PCI to LAD done 5 years ago. Now, this is the ISR. You can see a significant lesion in the proximal and the mid-LAD beyond that. And you can see the edges of the stent is marked out with the brown lines around that lesion. Now, when you look at an OCT, this is the OCT run. And what is important is when you look at this OCT run, you can see diffuse stable plaque distally, which is almost like 12 millimeters away from the edge of the stent. And I think these plaques don't need to be touched because they are not going to be causing any acute coronary syndrome. The mixed plaque proximal to them is more reflective at the edge of the stent, which is just close to the edge of the stent. You can see that it is highly lipid necrotic, and there's some specks of calcium in that as well. And you can see at 4 o'clock, you can see cholesterol crystallization quite clearly. When you come at the proximal end, you can see another lesion, which is typical, which is the other one, where again, you can see a complex plaque with a ruptured plaque distally to that. I mean, if you went on a little longer in the longitudinal view, you can see a complex ruptured plaque. And again, when you get to the proximal end, you can see the stent was possibly undersized with a very large plaque burden at that site. So all those recipes for instant restenosis to happen. Now we need to correct it. And when we need to correct it, we need to find a landing zone. And I think the landing zone, we all have discussed this time and again, and we looked at all these images. And essentially, what is important is you need to take that large diagonal in the center And that large diagonal marks the circle in that area which I mentioned above. And that essentially divides the LED into the proximal half and the distal half. Now, if you look at the tapered artery concept, you know that this is going to be the this is going to be the proximal LED, and this is going to be distal to that diagonal branch is the area that you're going to expand to. So your target areas are going to have to become close to 3.0 millimeters and 3.5 millimeters respectively, before and after the diagonal branch. Having said that, once you achieve that, I think it is important to make sure they've achieved everything like you've actually planned. This is how we completed this angioplasty, and we've got almost around 85 to almost 100% of what we wanted to achieve in the expansion of the stent and covering it right up to the ostium, as you can see in the last image in the OCT. We need to end up with having a checklist. Did I have an edge plaque burden of less than 50%? Yes. Was it a stable plaque at the landing zone? Were there any complications that needed correction at the edges? Was there any significant malapposition or deformation of the stent? Was there plaque protrusion? Are the MSAs and expansion indices correct? And was the stent symmetrically expanded? If the answer to all these questions are ticked yes, then I think we've done a great job. Now, when we get into lesions which are of long-standing ISR from in-stent restenosis of many years, like in this patient, a stent was placed in the LED 10 years ago and came to us with a non-STEMI 10 years later. The lesion was actually uncrossable by any of the OCT catheters or IVUS catheters at that time. In 2016, we used the Atlantis system, and we had the very early OCT catheters. So this indicates that we need to do a rotational atherectomy. For me, this indicates rotational atherectomy 1.5 burr. And once I do that, we can then do a rotational, we can do an IVUS, an OCT. And this OCT shows the landing zones clearly marked to the right and the left, the proximal and the distal. You can see that the distal landing zone has a calcified little protrusion, minimally protruding calcified area. But I don't think that these calcified areas which protrude so minimally really cause an issue, and we can safely land stents here as long as the rest of the LED is accommodative of the expansion and the area. As you come within the lesion, you can see to the right is a very, very complex calcified circular, almost extending in the entire intrastent segment within the stent. And you can see that there's extension of calcium even beyond in the peristent area. And to the left, you can see the second image over there is the reason for that ruptured plaque, which is a very complex plaque, which is more lipid rich and with even a very high, with bright light reflections, which indicate macrophage infiltration. Now, after doing a rotational atherectomy, when you look at these kind of plaques, our concept has to be based on something more general. You cannot define plaque as circular or semicircular, but most of the times a calcified nodule, a shelf of calcium, an eccentric calcium, concentric calcium will all coexist along with a lipid necrotic plaque in that area. So our judgment has to be based on the entire image morphologies that we're seeing across the length of the treatment segment, and then choose our devices. And these are difficult because in those times, in 2016, when I did this, our choice was either a rotablator and then an escalation of burr size, followed by any of the high pressure technologies like either high pressure by a balloon, or it could be a high pressure balloon like an NC balloon, a Flextome, or sometimes it was, I'm not sure if we had the OPN balloon at that time in our cath lab. But this is neoatherosclerosis with plaque rupture. It's a complex mixed plaque with variety of lesions commonly seen with the first generation DS. Lesion preparation would require an aggressive rotational atherectomy by flextome. That is exactly what we did, and we got this result. This patient is since now 5 years, and he's doing well. And I think we expect him to do well beyond this as well. But as our checklist, when we look at our checklist, we had ticked almost everything, and we'd got everything correct in this. When I have to talk about this example, which came in with an RCA culprit lesion at that time, the LAD was good. A year later, had new unstable angina. The RC was okay, but the LAD had developed this lesion within 1 year. So naturally, we took this is the previous stent from 10 years prior to the first PCI, and then we do an OCT. And this is our OCT through the entire lesions. You can see a mixed, as I talked to you in the earlier time with the earlier case, that it's almost always a mixed potpourri of lesion types in this segment. And they are morely, in here we have the edge, the distal edge is densely fibrotic with calcium and no lipid core. The in-stent restenosis inside, this is a layered in-stent restent, a layered neointimal hyperplasia with no luminal encroachment of significance. But as you come to the proximal lesion, you can see that it's lipid necrotic. But even then, even though they appear soft, these are extremely resistant to dilate. And I've realized that the best thing for these is a flextome balloon in my practice, because I can use a 6 millimeter flextome quite effectively. And of course, the proximal edge dissection. Now, we fix this lesion, and once we fix this lesion based on these images, what we have is these two results. And this is your proximal result at the end. You can see the 2 layers of stent, even though, and this is the distal end. While in the proximal, we had met with most of our requirements of satisfaction, distally, look at this. We had not got us MSA and MEI optimal, and our stent was not symmetrical. There was plaque protrusion. So this was, in my opinion, an extremely suboptimal result, even though it's guided. Do I think that we did something wrong? No, we did nothing wrong, but I think we still left a very undesirable result as a result of the technologies available to us at that time. I feel excimer laser is the only technology which will predictably fracture peristent calcium. Everyone should read this paper. And I think that is that might have a huge play in in-stent restenosis of long duration. This is a recent case which we did 3 weeks ago, of a man who I operated 16 years ago and put in a stent in the ostium of the LAD. And if you look at this, lesion again, my stent, even though it was a precise placement, today you can tell that that stent had come and migrated over the ostium of the circumflex. So we know how poorly we did those things at that time. He came back 16 years later with an in-stent restenosis, and this is from 2020. And this we did with a high definition IVUS. I'm not going to go into the details of the IVUS because we're all familiar, but high definition IVUS is able to achieve all those things, especially in these people who are 82 years old with creatinines which are low and LV dysfunctions. And this is the result we achieved in him with a contrast utilization of less than 70 ml of contrast. This involved rotablator, IVL, and all the technologies required. But today, it looks like ISR needs to be imaged. The best way to treat ISR is to prevent ISR in the index procedure. And should we have in-stent restenosis, I think we need to make every effort to find out what caused it, and also in that will lay the answer of how to treat it. And we have to equip ourselves with all the current technologies, which are going to give us the most optimal result to treat them at this present time. And I tell you, this is the most difficult subset to treat. Thank you.
Kirti, excellent review and nice demonstration through your cases about how to go ahead with ISR and the different reasons, especially taking over time, whatever technology available, whatever understanding we had that point of time, and today what understanding we have with the current technology, especially imaging and so on. So I know this was more of imaging guided talk which was given to you, but any role of functional assessment in ISR? Do you believe in that, or you just do imaging and then extrapolate that information?
No, so there is, of course, a role of functional ISR. In fact, it's too late, and I had to cut off some of my slides because I know I would exceed time. But we have enough reasons to believe that there are ISRs which we think, and angiographically, we think it's an ISR. We do an FFR, and the FFRs are 0.94 or 0.93. I've shown those slides before. And of course, functional study is absolutely important. And that is when you're especially looking at multiple issues, like you have a culprit artery, which is artery A, and you treat it. And then you look at an incidental ISR, which you find on the angiography in an artery B, which was treated many years ago. I think when you know that that is happening, you need to be completely certain that you are dealing and you're going to touch an artery which is functionally restrictive, because unless these ISRs are less than 0.75, don't get into long-standing ISR PCI, because the results are not always great, and it is very difficult subset to treat when you have peristent calcium.
Yeah, good, great. So, yeah, Kirti, it's too late and multiple things.
Thank you.
Yeah, but we will go ahead with the last lecture of the day by none other than our organizing secretary of this conference. Excellent day we had. Of course, it was a bit long, but a lot of educative material in that. So, OCT guided PCI of acute stent thrombosis. Dr.
Dr. Vitisha, are you able to see, sir?
Yes, excellent. And we are able to hear you nicely.
I'm embarrassed to talk after Dr. Kirti Puramiya's excellent talk. Very beautiful presentation. So, as you all aware, the ST presents like a STEMI in 75% of cases and cardiogenic shock in 30% of cases, and requires emergency repeat PCI with optimal reperfusion strategies in 2/3 of patients. And it happens 0.5 to 1% of patients within 1 year after the procedure in second generation DES implantations. It is associated with very high 30-day mortality rate, that is almost 25 to 30%. And 20% of patients with the first episode of ST, they present with a recurrence of ST within 2 years. If you see the mortality, that is early stent thrombus or late thrombus, very late thrombus also, the 1 year and second year mortality is also very, very high. And majority of these patients present with STEMI, that is 82% presents with STEMI, and 15% of the patient presents with NSTEMI, and 3% they present with unstable angina. Definite stent thrombus, you are all aware the presence of ACS with angiographic or autopsy evidence of occlusion. And probable ST, unexplained death within 30 days after the procedure, or acute MI involving the target vessel territory without angiographic confirmation. Possible stent thrombus, all unexplained deaths occurring at least 30 days after the procedure. So acute, that is first 24 hours, subacute within 30 days, and late between 1 month and 1 year, and more than 1 year, we say it is very late stent thrombus. So stent thrombosis may be because the patient-related factors, or maybe lesion-related, or because of the drug-related or procedure-related. So if you see, very common causes are undersizing. It may be dissection or TIMI flow. When you are doing the TIMI grade flow is less than 2, or like a proximal or distal, that is more than that plaque burden indirectly. These bifurcation lesions are associated with high incidence of stent thrombus. The other factors like a malignancy and patient discontinuing DAPT or aspirin, and LV ejection, low ejection fraction also associated with high stent thrombosis. Because I'm trying to expedite the presentation, mainly I will focus on the imaging. You have to see for mechanical causes and biological causes. If you see, it may be because of the underexpansion, maybe because of the medial edge dissection, or geographical miss. That means the plaque burden distal landing zone or proximal landing zone is very, very high. That is more than 50% of the plaque burden, particularly landing in a thin cap fibroatheромata, a lipid-rich plaque, or calcium mark more than 71 degree, or fibrous plaque burden more than 15%. Or if there is because the neoatherosclerosis or dismantling, this is seen in patients with the BVS implantation, where because as the BVS struts gets resorbs, what happens because some of the stent particles may fall into it may collapse into the lumen, that may migrate and it may lead to thrombus formation or malabsorption, or it may be evagination. This is seen in DES patients, particularly most often seen in patients with first generation DES. A finger-like projections, these may form a focus for thrombus formation or nidus for thrombus formation. These finger-like projections just between the stent struts, you can see the finger-like invaginations, and these are associated with the high incidence of stent thrombus or uncovered stent struts. And these uncovered stent struts, due to lack of endothelialization, also may be associated with stent thrombus. I'll show a few cases of stent thrombosis. You can see here the stent is implanted, but here you can see very clearly haziness, and it may be because of the thrombus or it may be because of the edge dissection, but you see the OCT showed very clearly thrombus. You can assess the thrombus area, and you can also, what is the area, volume, everything you can estimate. And this, if you don't cover it, definitely it may lead to further aggravation of the thrombus. This is another case, 53-year-old male presented with ACS. Patient underwent PCF right corner in 2012. At that time, we used 4.5 into 25 mm Optima tacrolimus eluting stent to the proximal RCA, mid RCA. Was treated with 3.5 into 20 mm cobalt chromium stent and proximal to mid overlapping stent with cobalt chromium stent. So he presented with the inferior wall NSTEMI, and this is the angiograph picture. You can see the left system is fine, but if you see the right coronary, there is a very, very tight thrombus. He underwent the initial procedure in 2012. He came with NSTEMI of inferior wall MI, and this is the picture. Then we did we used the right radial approach, slender sheath, and 7 French JR. You can see the cyan blue crossing. And then we did the pre-dilatation mainly to acquire the very good image. And you can see the OCT acquisition. See, it's because of the neoatherosclerosis. You can see very clearly, and this is the distal to the stent. But if you see the stent portion, macrophages you can see very clearly. And you can see the vasa vasorum you can see. And this one also, you can see the plaque rupture leading to thrombus formation. You can see the lipid plaque very clearly. And you can see the vasa vasorum. And this is more of a lipid-rich plaque. And I will show the analysis. You can see very clearly, here is the area of neovascularization. And if you see here, the plaque rupture. A neoatherosis, plaque rupture leading to thrombus formation. You can see it's because this. You are able to see the areas of spotty calcification also. So macrophages, you can see vasa vasorum, you can see plaque rupture, you can see the red thrombus. So indirectly, the cause of ISR is because of the neoatherosclerosis with plaque rupture leading to thrombus formation. So this has to be covered with a drug-eluting stent. Then we used 4 into 38 mm stent. And this is a distal RCA was stented with 4 into 15 mm. Because distal to the stent, there is a progression of atherosclerosis with a significant narrowing. And it was post-dilated with 4.5 into 12 mm. This you can see post-procedure, we are assessing the max. There is no medial edge dissection and opposed and well-expanded stent. But in the mid-zone, you can see, though it's expanded well, but proximally 4 square mm, and you can see here 4.4 distally, then the mid portion is only 3.6 square mm. Then we thought of we'll upsize the balloon and we'll expand it further because already patient presented with ISR. Then this was corrected with the NC. Then we got the finally 4.5 mm. So this is a post-procedure angio. So neoarthrosis may present with like a lipid plaque or neointimal plaque rupture, calcific nodule you can see, and you can see the calcified plaque inside the neoatherosclerosis, and it can present like a white thrombus with erosions and plaque rupture associated with red thrombus. This another patient, 67-year-old male, hypertensive, presented with chest pain associated with giddiness, nausea of 3 days duration, and he came to us with acute infraval MI, pulmonary edema, complete heart block, and he was subjected with a TPI, past history of PCI of RCA. He underwent a BMS in 2002. Presently, this was done about 2 years ago and presented with acute infraval MI. This 2D echo, while doing 2D echo, it also showed atrial fibrillation. And you can see the very clearly the LCX disease there, but right coronary, very, very tight lesion, very critical lesion. Proximal right, 99% ISR with acute stent thrombosis. Distal, 70% lesion, PDA PLV, normal. Patient present with complete heart block. You can see the temporary pacemaker lead. And again, right radial root, GR 3.5, 6 French. And pre-dilatation with Tajuna, mainly to acquire the good image. You can see very clearly proximally a calcium and a thrombus, red thrombus you can see very, very clearly. You see the neoarthrosis, plaque rupture with red thrombosis. So you can assess exactly what is the cause. And you can see very clearly unhealed. If you see the distally, previously patient had an edge dissection. Though it's healed, still it's you can see the evidence of the distal dissection, and you can see the calcium plaque distal to the stent, and you can see some areas of evaginations, and this is spotty calcification. When you see the spotty calcification, that itself indicates neoatherosclerosis. You can see the stent starts. And in some areas, you can see very clearly. Then we assessed the stent length. What is the landing zone? That the diameter is 2.65 mm distally, proximally diameter 3.4. So device selection, you can see the length and landing zones we are choosing. Very nice landing zones you have to choose. And you see the proximal landing zone is fine without any, not much plaque burden. And you can see the proximal landing zone, the diameter is 3.8, that is luminal. If you take it, it's almost 3.5. Distal landing zone, that is diameter is 2, but if you take the external EL diameter, it's almost 2.8. And this is the, you can see the thrombus very clearly here. You can see the thrombus. And this is the pre-dilatation with the 2 mm Tajuna. Then we implanted with the 3 into 38 mm with the guideline support. And you can see post-stent check angio. Then dilated with 4 mm balloon. This is the post-stent image. Then we acquired the, you can see here some plaque burden is there. So then we interrogated with the OCT again. Distal RCA stented. But before that, we acquired the image. I'll show the before stenting, the image what we acquired. It showed a significant plaque burden. It showed the significant plaque burden distally and almost significant maloposition proximal stent, that is 30% maloposition. You can see distally there is a plaque. The here area is 5.6 square mm, but here 3.6, distal to the stent. There is a plaque burden. You can see proximally there is a maloposition, almost 30% mal, which is very significant, and the width is more than 400 micrometers. And here apposition is very well. Here also opposed very well, but proximally maloposition, distally plaque burden. So you can see very clearly this has to be rectified. Otherwise, during next procedure, sometimes the wire may go between stent struts and the vessel wall, and there will be a difficulty and it may lead to distortion of the stent edge. And sometimes when you are engaging also, even when balloon may go in between or catheter guideline may go in between, it may lead to LSD, longitudinal stent deformation. So because the malabsorption was more, then we took the 4 mm into 18 mm NC to oppose the stent struts very well. And distal landing zone, you can see a very thick plaque burden. The calcific plaque more than 70 degrees, that itself may lead to ISR. That's the reason it has to be rectified. So this was covered with additional stent, that is almost 11.8 mm. So this additional stenting. Then L6 was stented, LM to L6 stent was stented. This is the final result. So when you see the Prestige registry, the causes may be because of the neointimal hyperplasia or edge dissection, neoatherosclerosis, or late acquired malabsorption. It may be because of underexpansion. You can see the evaginations very clearly, maybe evagination or crushed stents, sometimes inadvertently because the abdominal passage of the balloon or guide liner, it may crush the stent. So these are the causes, very common causes which were described in Prestige registry. And if you see the causes, the acute and subacute and late, very late stent thrombus cause also, they have elaborated very nicely. This is based on PESTO, edge dissection, malabsorption, evaginations. These are the evaginations. This is a neoatherosclerosis, again plaque rupture. These are the common causes of the stent thrombosis, which were described in PESTO registry. And this is INVEST registry, where they showed various causes of the stent thrombus. When they analyzed, underexpansion was seen in 11%, and neoatherosis was observed in 18% of patients. Malabsorption was observed in 18% of the patients, and 42% scaffold discontinuity. This is they observed mainly in BVS. And other one is other causes are 11%, observed in 11% of patients. So platelet function testing is they did, and it showed very high platelet reactivity, but always give the best 1 year, minimum 1 year DAP therapy, and preferable to give a prasugrel or ticagrelor combinations wherever it is needed. And at least for 1 year you maintain as per the guidelines. And if you see how to manage the management of stent thrombus, if you see these stent thrombosis, if it is a definite stent thrombosis, first to find out the culprit lesion and deocclusion. That means if thrombus aspiration or simple balloon dilatation, deocclude and establish some flow to get the good OCT imaging. And after OCT analysis, you analyze, is it because of the ruptured neoatherosclerosis, or is it because of the neointimal hyperplasia, or is it because of the edge disease progression, like a stent proximal edge or distal edge atherosclerotic progression, or it because of the edge dissection, proximal or distal edge dissection, medial dissection. These cases, if you find these type of etiology, you have to rectify it with a stent or DEB. Suppose if there is severe malabsorption, underexpansion is there, severe malabsorption is there, or coronary evagination is there, you can do the POBA, high pressure POBA you can do, or if the DEB also you can try with high pressure DEB. If you see isolated uncovered struts or no underlying mechanical cause is there, you treat it medical. That is very, very important. Whether platelet testing, everything, do it. Any other cause of whether patient is discontinued, whether he is not taking regularly, or if he is taking propofol, switch on to the prasugrel or ticagrelor, and any other cause of stent thrombus there, evaluate medically and treat appropriately. So IVS and OCT should be considered to detect stent-related mechanical problems leading to restenosis and stent thrombosis. So in all stent patients with stent thrombus, liberal use of intracoronary imaging in order to detect and modify underlying mechanical factors is recommended. It's a mandatory to know the cause and to rectify the cause. It's strongly recommended in 2018 guidelines of ESC. So standard workup and management protocol does not exist for stent thrombosis. Thorough clinical evaluation is mandatory with a focus on risk factors for stent thrombosis. You see, is it because the stent implantation related issues or because the medical conditions, and evaluate and manage it accordingly. Liberal use of intracoronary image is mandatory. Analysis of thrombus aspirate does not provide any actionable information, and its role in the treatment of ST is restricted. Management in the cath lab should consist of correction of any underlying mechanical cause, ensuring an optimal result post PCI, usually with the implantation of DES. So always identify the cause of the stent thrombosis and manage it accordingly. Imaging definitely helps in identifying the cause and rectifying the cause and optimizing the DES results, which will provide the better long-term results. Thank you, one and all, for paying the attention.
Thank you, Dr. Sridhar, for that excellent demonstration, good cases, good visuals, images, and review of the literature.
Thank you very much.
Wow, it's a nice way and a good collection of cases. I think one of the most important causes also in our country is discontinuation or disruption of the antiplatelet therapy. And sometimes it is also important to know that if the OCT only shows thrombus with all the other characteristics, no mechanical factors and all that, maybe by just simple antiplatelet therapy or 2B3 antagonist and some anticoagulations, we can get away with it. Otherwise, people tend to put in a stent without any imaging. Without knowing what the exact cause is, and then they put in a long stent, and by chance, if the cause is some other mechanical which is not corrected, you'll end up in restent thrombosis. So that's the situation. That's why what you said and showed images is very important to decide what is the exact therapy in this case.
I feel particularly ISR and stent thrombosis, the strong recommendations for
imaging
evaluation. Because whether you use IVAS or OCT, ultimately
any stent failure is a very strong indication of any type, whether it is ISR or thrombosis. It is definitely needed, and by and large today I think imaging is fairly well available in all the cities. Maybe it might take 24 hours to get in one image modality, but otherwise it's freely available. Of course, 15 to 20% now have inbuilt in-house imaging facilities, so I think we should use it, even if it is at the middle of the night, because all these stent thrombosis patients, they come at odd times.
I think with this note, we can conclude today. I think we had a very beautiful and very nice session, and involving many experts across the country and international faculty. And there is a good discussion. Many people have shown very nice cases. They illustrated how the imaging useful and how the complex PCI you can make simple and you can understand better. And even we have even Dr. Balbir Singh and Dr. Gopal Krishna showed very beautiful cases, how the imaging helps in understanding and addressing the issues of the complex PCA. I think with this note, I will ask Dr.
And special congrats to you, Dr. Sridhar, to start the opening conference of this year.
Thank you very much, sir.
Thank you. Stay safe. Good night.
Good night. Good night, everyone.
See you tomorrow.
See you tomorrow evening. Thank you very much, sir. Ravi. Yeah, I think Ravi.
I'm listening, sir. We'll conclude. Thank you, sir. Good night.
Anything you want to say, Ravi?
No, sir. We are good.